Hello my dear friends, welcome back. This is Dr. Azam here, your faculty of anatomy at PrepLadder. And now we are going to discuss all the questions of anatomy which has been asked in the FMGE Pulse Test, which was conducted on 3rd December. So now let us see all the questions one by one. Let's begin with the first one. A newborn had hypoplasia of mandibles and zygomatic bones, malformed external ears and the slanted palpebral fissures. Abnormality in the development of which of the following pharyngeal arches will most likely lead to the given condition. So basically we need to see which pharyngeal arch is giving rise to this mandible and zygomatic bone and so on, which is mentioned in this question here. Now there is one best diagram to learn about the derivatives of the pharyngeal arches. I hope you have seen this diagram. I have shown you in our regular videos. Now in this diagram we can see that malleus and incus, they are derived from the first pharyngeal arch. Along with that, the anterior ligament of malleus, along with that the sphenomandibular ligament, the mandible and the maxilla, all these structures present over here are actually derived from the first pharyngeal arch. So I repeat again, the first pharyngeal arch is the one which is going to form the malleus, incus, the anterior ligament of the malleus, sphenomandibular ligament, mandible, and even that is also going to form the maxillary process. So basically all these structures are formed from the first pharyngeal arch. Now in the question it is mentioned that there is a defect in the development of all these structures, and of course that will be due to the defect in which pharyngeal arch? The pharyngeal arch number 1. So the first pharyngeal arch will be the right answer here. Moving on to the next question now. Please identify the structure indicated in the given image below. Is it midbrain or the pons or medulla oblongata or spinal cord? Now during our anatomy classes, in our anatomy videos, I have shown you this diagram of the sagittal section of the brain many a times. Now in the sagittal section of the brain, this one here will be the spinal cord here. Just above the spinal cord, this part here will be the medulla oblongata here. Then just above this one here, this is pons. Now behind the pons and medulla, this part here will be the cerebellum. Now we know that the pons, medulla and cerebellum, all the three of them together are going to form your hindbrain. And the ventricle of the hindbrain here, this will be the fourth ventricle here, sir. Perfect. Now keeping this in the mind, if you just look at this radiological image over here, of course this big structure here, which is actually like bridge-like structure over here, is nothing but the pons here, sir. So the correct answer here will be pons. Perfect. Moving on to the next question here. A patient underwent a left mandibular submandibular gland excision during which the hypoglossal nerve has been injured. So the 12th cranial nerve is injured. Which of the following deficits would be seen in this case? First, let us try to recall the 12th cranial nerve, hypoglossal nerve. It is the one which will be supplied to all the muscles of tongue except paladoglossus. And paladoglossus is the one which will be supplied by vago-accessory complex. That is what is a normal thing that we have learned. Now suppose if we need to test the 12th nerve, then we'll ask the person to protrude the tongue. So first let me tell you about the normal, then I'll tell you the abnormality. In normal people like you and me, what is going to happen? Whenever you ask the person to protrude the tongue, both the genioglossus muscle on both the side will be acting together and the tongue will be coming out straight. It will be protruding out straight like this here. Now suppose if my left side hypoglossal nerve is injured, the 12th cranial nerve is gone. So therefore the left genioglossus muscle will be paralyzed. Now if you ask this person to protrude the tongue, then what is going to happen? Now the left side genioglossus muscle is paralyzed here, but the right side genioglossus muscle is still working. So therefore when the person is trying to protrude the tongue, the right genioglossus will be like more dominant and that is going to push the tongue towards the left side. I mean to say on the same side where the nerve has been injured. So remember, if the tongue is deviating towards the left side, it means the left hypoglossal nerve is injured there. Is it okay? So therefore, when the patient is asked to protrude the tongue deviates to the paralyzed side and that will be the site of the lesion of which nerve? Hypoglossal nerve. Now let us see all the options one by one. The tongue will be deviated onto the contralateral side. Absolutely wrong. That is ruled out. The deviated tongue to the same side. Absolutely correct. Inability to protrude the tongue, this is also wrong. It can't be the right answer there. Why? Because person is able to protrude the tongue, but the tongue is deviating. Loss of taste sensation in the posterior one-third of the tongue, this cannot be the answer. Why? Because hypoglossal nerve has nothing to do with the taste of the tongue. And remember, from the posterior one-third of the tongue, the taste as well as general sensation, both of them will be carried by ninth nerve, that is your glossopharyngeal nerve, sir. And I told you that very clearly with the help of a simple mnemonic 5, 7, 9, 9, 10, 10. So you can remember the nerve supply to the tongue, sensory supply to the tongue will be by 5, 7, 9, 9, 10, 10. Perfectly done, sir. So the correct answer here is the tongue is deviating towards the same side of the injured side of the nerve. Next one, sir. What is the function of the muscle indicated in the provided image? First, you try to identify this muscle. This muscle is inserting onto the greater tubercle here. And this muscle here will be the supraspinatus muscle. And this muscle is passing above the spine of the scapula, supraspinatus muscle. Perfect. And supraspinatus muscle is helping in 0 to 15 degrees abduction of arm. It is helping in 0 to 15 degrees abduction of arm. I can say that it is helping in initiation of the abduction of the arm. So remember, supraspinatus muscle is helping in 0 to 15 degrees abduction of the arm. 15 to 90 degrees will be done by deltoid muscle. To be very specific, the lateral fibers of deltoid. And above 90 degrees, it is done by trapezius along with serratus anterior. Fine. Now, what is the function of this muscle marked here? Of course, the correct answer will be abduction at the shoulder joint. Perfectly correct. Moving on to the next question right now. What is the vertebral level of the abdominal plane labeled as 2 here? Now, in this diagram, I can see here, this is the abdominal plane which is labeled as 2 here. Now, let me show you one more image here to get like more clarity here, my dear friends. Now, in this diagram, you are able to see here, this one will be the costal margin. This is the costal margin here. And this plane is the one which is going to touch the lowermost part of the costal margin. That is the reason why this plane is referred to as subcostal plane. And we can very clearly see here the subcostal plane is passing at the level of L3 and that too at the upper border of L3. Now, if you compare this diagram which is given in this question here, of course, that plane which is marked as 2 here will be the subcostal plane and that is passing at the upper border of L3. Perfectly done. Now, moving ahead with the next question here. The image shows the cross section of the abdominal cavity. Identify the marked structure A. Now, the moment you are looking at this image here, there is nothing but your diaphragm. Diaphragm will be dome shaped and we have actually lifted it like this and we are seeing from below. And in diaphragm, there are like 3 major openings and those 3 major openings we remember with the mnemonic as Voice of America. So, this one here will be the vena cava opening. This one here will be the esophageal opening here. And finally, this opening here will be the aortic opening here. And aortic opening we can easily identify. Why? Because it is between the right and left crus of the diaphragm. So, between the 2 crus of the diaphragm, you will be able to appreciate the aortic opening. And of course, from the name itself, we can understand that aortic opening is allowing the passage of aorta. Of course, which aorta? Descending aorta. And that is the place, once it is going to cross the diaphragm, it is going to become abdominal aorta. So, first we will call it as thoracic aorta and that is going to become your abdominal aorta. So, what is going to pass from the aortic opening here, sir? The correct answer here will be the descending aorta. Descending aorta. Now, not only descending aorta, along with the aorta, there will be even azygous vein passing from here along with the thoracic duct. The azygous vein and the thoracic duct along with the aorta are going to pass through aortic opening of the diaphragm. So, option A will be the right answer here. Moving on to the next question. Which of the following arteries is palpated in the given image below? Now, in this given image, the doctor is trying to palpate in the tarsal tunnel. Tarsal tunnel. Now, where exactly you have this tarsal tunnel? Please look at this diagram here. Now, in this diagram, this one here will be the medial malleolus. This one here will be the medial malleolus. And this one here, your heel bone, that is your calcaneus. Now, between the medial malleolus and the calcaneus, there is a fibrous band-like structure over here that is referred to as flexor retinaculum. And because of the flexor retinaculum, there is a formation of tunnel here and this tunnel here will be the tarsal tunnel. That is your tarsal tunnel. Now, what are the structures which are going to pass from the tarsal tunnel? Number 1, there is a tendon which is present just behind the medial malleolus and this tendon here will be the tibialis posterior tendon, and then just behind that one more tendon here, that is the flexor digitorum longus tendon, and then there is one more tendon present over here, and this one here will be the flexor hallucis longus tendon. So totally there are like 3 tendons passing from here. First you will be having tibialis posterior, then there will be the tendon of flexor digitorum longus, and then lastly you will be having the flexor hallucis longus. In between this, I hope you are able to appreciate one nerve present over here, and of course that is your tibial nerve. And nowadays the trending question in your exam, the most important one, the artery here, and this artery here will be the posterior tibial artery. Very much important for your exams nowadays. Posterior tibial artery. Now the image which is depicted over here in this question, there the doctor is trying to measure the pulse, and that pulse is measured by which artery over there? That artery will be the posterior tibial artery. So you are trying to palpate the pulse over there, that is by which artery? Posterior tibial artery. Apart from that, all these structures which are going to pass through the tarsal tunnel, you also have to remember them in order, and to remember them in order, we have a mnemonic here, that is Tom, Dick and Harry. Okay, Tom, Dick and Harry. So in this manner we are going to remember. So T stands for tibialis posterior, D stands for digitorum longus. Of course it can't be extensor, it will be the flexor digitorum longus. After that, H here stands for the hallucis longus, flexor hallucis longus. So Tom, Dick and Harry will be using this mnemonic for remembering the order of all the structures over here. Now moving ahead with the next question. After a fall from a height with his hand outstretched, a man is brought to the emergency department. An X-ray reveals a fracture in the clavicle. Which specific region of the clavicle is most likely to be fractured? Now let us discuss the entire topic of the clavicle over here. In clavicle, remember, mainly you got to learn about the peculiarities of the clavicle. Now the first peculiar feature, clavicle, is it a long bone or a short bone? Remember, it's actually a long bone, and that too it is only horizontally lying long bone present in our body. It is only horizontally lying long bone present in our body. Now normally long bones will be having medullary cavity, but clavicle will not have medullary cavity. It is the first bone to start ossifying in the intrauterine life, almost around like 5th week of the intrauterine life. Remember, clavicle will start ossifying, but it is the last bone to complete the ossification almost by 25 years of your life. Okay, so in your books it will be given as 22 to 25 years of life. I am just telling you the maximum. By 25 years of life, the clavicle will be ossified. Now normally long bones will be actually ossifying from the cartilage. They will be undergoing cartilaginous ossification, but remember, clavicle is the one which will be ossifying in membrane. It will undergo membranous ossification except for a small medial end. And after that, remember, it is the only long bone which is actually having 2 primary centers of ossification. Normally long bones will be having only 1 primary center of ossification, but it is the one which will be having 2 primary centers of ossification. Now after that, let us see the fracture. Clavicle will be normally fractured at the junction of lateral 1/3 and medial 2/3. You can clearly see in this diagram here the medial 2/3 and the lateral 1/3. So this is the place where clavicle is most commonly fractured. Now according to the latest edition of Gray's Anatomy, that is 42nd edition, yes, nowadays they are not dividing the clavicle into like 3 parts there, they are dividing into 5 parts. So when it is divided into 5 parts, then the fracture of the clavicle will be most commonly between lateral 2/5 and medial 3/5. Lateral 2/5 and the medial 3/5. So therefore, my dear friends, remember, clavicle is most commonly fractured at the junction of medial 2/3 and the lateral 1/3. This is the right answer here. Now moving on to the next question here. Which of the following is the lining epithelium of trachea? Now in respiratory system, remember, you will be having pseudo-stratified ciliated epithelium, pseudo-stratified ciliated columnar epithelium. Now this epithelium, what is the meaning? Why the name is given like this here? We know very well stratified means it will be actually multiple layered. They are like many layers. But why the name is given as pseudo? Now what is going to happen here? For example, if this is the basement membrane, over here, now this is like one of the cell here, then another cell here, something like this. Now all these cells are placed on the basement membrane only. All the cells are present in the basement membrane only. That means it is a single layer only. But what is going to happen, because of the different sizes of the cells over there, their nuclei are appearing to be arranged at different levels. And because of this, it is falsely giving the appearance of a multiple layered cells, multiple layered epithelium. So please remember that it is not at all multiple layer, it is just a single layer. Because the nucleus is arranged at different heights there, it's appearing like a multiple layer. That is why it is referred to as pseudo. Falsely, it is appearing like multiple layered, pseudo stratified columnar epithelium. And pseudo stratified columnar epithelium, it will be present in trachea as well as the bronchus over here. So therefore, if you look at the option over here, yes, which type of epithelium do you find in the trachea? It will be pseudo stratified ciliated columnar epithelium. Moving on to the next question here. Which ganglia is located in the marked area? If you look at the diagram very carefully, the marked area there is actually the infratemporal fossa. Here you will be able to appreciate the temporal fossa here, and below that there will be infratemporal fossa. So in the infratemporal fossa, the ganglion which will be located will be the otic ganglion. That is otic ganglion. Apart from that, pterygopalatine ganglion will be obviously present in pterygopalatine fossa. But the arrow mark which is shown here is actually just below the temporal fossa, that is infratemporal fossa, and there you will be able to appreciate the otic ganglion. Perfect. A person who had a road traffic accident presented to the ER with the injury to bulbar urethra. And this is another very important concept nowadays. It is like a trending question in your exams nowadays, sir. Almost in every exam, there will be a question regarding extravasation of urine. And the main important thing is what is ruptured here? Yes, bulbar urethra. That is something important to remember. What can be the location of collection of urine due to this injury? Now, my dear doctors, let us see here one by one. Now, if the bulbar urethra is ruptured, first of all, remember the example here. Rupture of bulbar urethra will be due to straddle injury. Straddle injury, nothing but riding a bicycle on the bumpy road. So when the person is riding the bicycle on the bumpy road, there will be straddle injury. Straddle injury, what is going to happen? Bulbar urethra will be ruptured. If this is ruptured here, the urine will be going out into superficial perineal pouch. Number 2, the urine will go into the scrotum here. Number 3, the urine will also go into the penile shaft, the shaft of the penis, as well as the urine will also go into the anterior abdominal wall. Oh my God. You can see if there is rupture of bulbar urethra, then the urine will be going out into superficial perineal pouch, the scrotum, as well as the penile shaft, as well as into the anterior abdominal wall here. Fine. So now let's try to look at the options one by one here. What can be the location of collection of urine due to this injury? So inguinal pouch, peritoneal cavity, ischiorectal fossa, and the anterior abdominal wall. The right answer here will be the anterior abdominal wall. So that is the correct answer here. It can't be into other places which are given here. It's into the anterior abdominal wall. Now, apart from that, let me tell you about one more important thing here, that is a rupture of membranous urethra. When the membranous urethra is ruptured, remember the urine will extravasate out into the deep perineal pouch. The urine is going out into the deep perineal pouch. Not only that, the urine can also go into the space present around the neck of the urinary bladder. And that space present over here will be the space of Retzius. Space of Retzius. Now, what is the cause? Why is this membranous urethra ruptured? Remember, membranous urethra will be ruptured due to, yes, the pelvic fracture. You got to find out that keyword in the exam. Whenever the clinical question will be given there, in that clinical question, find out the keyword pelvic fracture. So, when there is pelvic fracture, of course, membranous urethra will be ruptured. In the pelvic fracture, membranous urethra will be ruptured and the urine will be extravasating out into deep perineal pouch and space of Retzius. When there will be a straddle injury, bulbar urethra will be ruptured and the urine is going out into superficial perineal pouch, into the scrotum, penile shaft as well as anterior abdominal wall. Now, this is the places where the urine is actually extravasating out. But sometimes in your exam they are also asking where the urine cannot go and what is the reason for that one. If bulbar urethra is injured, urine cannot extravasate out into thigh. Why? Why? Because there is a fascia present there, that is fascia lata. Similarly, the urine cannot go into the deep perineal pouch due to the presence of which membrane? Perineal membrane present over there. Similarly, the urine cannot go into ischiorectal fossa. Why? Because of the presence of Colles fascia. So not only places where the urine is going, you also have to remember where the urine cannot extravase it out and what is the reason for that one. I hope this is clear. Now once you are clear with this one here, a 27-year-old male was climbing the stairs. Suddenly he fell and an iron nail hit on his neck. After the injury, the patient is having a hard time shrugging his shoulder. So is unable to shrug the shoulders. Now try to recall, shrugging of shoulders is done by trapezius muscle. Trapezius muscle is actually helping in shrugging of shoulders. And is having difficulty in turning the head. Turning the head, it is actually done by what, guys? It will be done by sternocleidomastoid muscle. This might be due to injury to which nerve? Of course, sternocleidomastoid muscle and trapezius muscle, both of them will be supplied by spinal accessory nerves. So if the spinal accessory nerve is gone, of course, the trapezius muscle as well as sternocleidomastoid muscle are gone. The person will be having a very hard time to shrug the shoulders as well as turn the head. Perfectly done, sir. Moving on to the next question right now. A 34-year-old female who works as a maid complained of knee pain and swelling. Which of the following area gets damage in housemaid's knee? Is it like suprapatellar bursa or prepatellar bursa or infrapatellar bursa or pes anserinus bursa? Remember, in the housemaid's knee, how to understand the concept here? Housemaids normally while mopping the floor. So while mopping the floor, they are kneeling down. And when they are kneeling down, what is going to happen? Yes, the bursa which is actually present right in front of the patella, that is prepatellar bursa, that will undergo inflammation here. So that will be the bursa that will be involved in housemaid's knee. That is your prepatellar bursa. Okay. And apart from that, the infrapatellar bursa will be actually involved in the clergyman's knee. So please remember these two things very carefully here without getting confused. Prepatellar bursa will be involved in the housemaid's knee, whereas infrapatellar bursa, that will be the one which will be involved in clergyman's knee. So I hope this concept is also very much clear. And by this, my dear friends, we are done with all the questions that were given in your test, and I hope all the concepts are like crystal clear. Thank you. All the best.
Hi everyone, I hope you found all 15 biochemistry MCQs asked in the last Pulse exam to be very easy. Now let's discuss all 15 MCQs. This is the first question. The lab technician observes that a urine sample obtained from a 4-year-old male appeared normal initially, but underwent a change in color as depicted in the image after a few hours. As you can see here, urine turns dark on standing. Immediately, your answer should be alkaptonuria. Just remember, alkapton means black. Alkaptonuria is a black urine disease, and this is caused by the defect of tyrosine metabolism, and the enzyme that is defective is homogentisate oxidase. So just from the first statement, you know it is alkaptonuria caused by the defect of homogentisate oxidase. Let's read it further. Subsequently, the color intensified over the following hours. Which enzyme deficiency can potentially lead to this condition? They have not even asked enzyme. Which deficiency can be the probable cause? We know the answer is homogentisate oxidase defect. And for completion's sake, let me tell you about other choices as well. If you look at choice A, beta carotene, right? Beta carotene is a precursor of vitamin A. And if it is beta carotene or vitamin A deficiency, it presents with eye manifestations. You know, it starts as night blindness or nyctalopia, delayed dark adaptation time, and then it presents with dryness of conjunctiva, bitoid spots, corneal xerosis, keratomalacia, corneal scar, corneal opacity, and they present with phrenoderma. It has got nothing to do with urine turning dark on standing. So the answer is choice D. How about choice B? Tyrosine transaminase defect. In the name tyrosine transaminase, you see two T's. Defect causes type 2 tyrosinemia. So tyrosine transaminase defect causes type 2 tyrosinemia. And type 2 tyrosinemia is otherwise called as Richner-Hanhart syndrome or oculocutaneous syndrome. So what do you expect in oculocutaneous syndrome? In this condition, the child presents with painful corneal erosions, hence the name oculo. Cutaneous because they present with palmar hyperkeratosis. So what are the manifestations of type 2 tyrosinemia caused by the defect of tyrosine transaminase? It is oculocutaneous syndrome. It presents with painful corneal erosions and palmar hyperkeratosis. Here the manifestation is urine turns dark on standing. Hence, this is not the right choice. How about choice C, ascorbic acid deficiency? We know vitamin C or ascorbic acid deficiency causes scurvy. What do you see in scurvy? Bleeding gums, petechiae, right? Hemorrhages, petechiae, joint pain. These are the manifestations that you expect whenever there is vitamin C deficiency. Hence, the answer is alkaptonuria caused by homogentisate oxidase defect. Okay, so answer for this question is choice D. The next question, this is about electron transport chain inhibitors. This topic is being repeatedly asked. The question is complex 4 is inhibited by. The answer is choice B or cyanide. Okay, answer is choice B or cyanide. How about other choices? Look at choice A, rotenone. Rotenone has got 1 in it. Just remember, rotenone has got 1 in it and it inhibits electron transport between complex 1 and Q. Okay, rotenone inhibits electron transport between complex 1 and Q, not complex 4. How about choice C, carboxin? TTFA and carboxin inhibit electron transport between complex 2 and Q. TTFA starts with T. It inhibits electron transport between complex 2 and Q. Okay. Antimycin. BAL and antimycin inhibit electron transport between complex 3 and cytochrome C. Okay, so I'm repeating this. How about choice A? Choice A, rotenone between 1 and Q. Choice B, cyanide inhibits complex 4, the last complex. Choice C, carboxin, TTFA and carboxin inhibit electron transport between complex 2 and Q. Antimycin, BAL and antimycin inhibit electron transport between complex 3 and C. So the answer here is choice B, cyanide. Okay. Now this MCQ says a female is diagnosed with lead poisoning. Which of the following enzyme defects is primarily responsible for the hematological abnormalities observed in this condition? Okay, we know lead poisoning causes sideroblastic anemia. If you don't know this, please remember lead poisoning causes sideroblastic anemia, and this is primarily because it inhibits the last enzyme of heme synthesis, which is heme synthase. It is also called as ferrochelatase. Okay, it is because it inhibits the last enzyme, which is heme synthase, otherwise called as ferrochelatase. So what is the right answer here? The right answer here is choice C. How about other choices? Lead inhibits ALA dehydratase, not ALA synthase. Do you understand this? So choice A is false. Lead does not inhibit uroporphyrinogen decarboxylase. B can be excluded. Yes, lead inhibits coproporphyrinogen oxidase, but that's not the primary reason behind why it presents with sideroblastic anemia. So just remember, lead inhibits 3 enzymes of heme synthesis. It inhibits ALA dehydratase, it inhibits coproporphyrinogen oxidase, and it inhibits ferrochelatase, otherwise called as heme synthase. So the right answer here is choice C. This MCQ is about fed state and fasting state. The question is, in a fasting state, glucagon promotes the production of glucose by which of the following pathways? Right? In the fasting state, primary aim of the body is to maintain blood glucose. To maintain blood glucose, we have just 2 pathways. One is liver glycogenolysis, the other one is gluconeogenesis. So the answer for this question is glucagon maintains blood glucose by stimulating liver glycogenolysis and gluconeogenesis. If you want to know more about fasting state, forget about fasting state. Anybody who's alive will have to maintain blood glucose. For maintaining blood glucose, we have 3 mechanisms or 3 ways. The first way obviously is dietary glucose. Dietary glucose maintains blood glucose for the first 2 to 2.5 hours after the previous meal. Suppose you have your breakfast at 9 a.m. till 11 to 11:30 a.m. Dietary glucose will maintain plasma glucose. After which contribution from dietary glucose decreases. Now to maintain blood glucose, liver glycogenolysis is stimulated. So when does liver glycogenolysis begin? It begins 2.5 hours after the previous meal. And it can maintain blood glucose till 12 to 18 hours of starvation. This range of 12 to 18 hours is because if the person has got adequate glycogen storage, then blood glucose can be maintained till 18 hours. If there is not enough glycogen, then it can maintain blood glucose till 12 hours. In either case, for the first 12 to 18 hours, blood glucose is maintained by liver glycogenolysis. And then it is gluconeogenesis. Gluconeogenesis begins 6 hours after the previous meal. Though it begins 6 hours after the previous meal, as I told you previously, for the first 12 to 18 hours, it is the liver glycogenolytic pathway which maintains blood glucose. So the answer for this question is glycogenolysis and gluconeogenesis, which is choice B. So this question, it's a repeat question, meaning this has been previously asked in FMGE. Okay. What is the most appropriate dietary recommendation for a middle-aged man diagnosed with a rare variant of pyruvate dehydrogenase deficiency, resulting in high anion gap metabolic acidosis? What is the dietary recommendation? I'll tell you the answer first and then I'll explain this to you. The person has to be given low carbohydrate, high fat diet. Okay, so what is the right answer here? Low carbohydrate, high fat diet, which is choice C. Let me explain why. Okay, so what does pyruvate dehydrogenase actually do? Pyruvate dehydrogenase converts pyruvate into acetyl-CoA. From where do we get this pyruvate? We get this pyruvate from glucose. So carbohydrate in the diet gives rise to glucose in the intestine. That glucose enters into the cell. Within the cell, glucose becomes pyruvate. Then pyruvate dehydrogenase complex converts pyruvate into acetyl-CoA, after which acetyl-CoA enters into citric acid cycle, comes out as carbon dioxide. Okay. Now tell me what is expected when this PDH complex is not active. In that case, pyruvate cannot be converted to acetyl-CoA, so pyruvate accumulates. When pyruvate accumulates, then it gets converted to lactate. That causes lactic acidosis. This lactic acidosis is responsible for high anion gap metabolic acidosis, which is given in the question. So now your aim is to avoid this high anion gap metabolic acidosis, for which you should not allow pyruvate to accumulate. How will you avoid pyruvate from getting accumulated? From reducing the source. What is the source? Glucose is the source. So the diet should not have carbohydrates, but the body needs energy. If carbohydrate is not going to act as a fuel, let us provide a fuel which is not dependent on PDH complex. Which fuel is not dependent on PDH complex? Fat. Because if the person is on a high fatty diet, fat gets digested to give fatty acids. Then these fatty acids get oxidized to form acetyl-CoA. It bypasses PDH step completely, goes and becomes acetyl-CoA, that then enters into citric acid cycle. So the person will be able to get energy. That is why the person should be fed on what kind of diet? The person should be fed with low carbohydrate, high fat diet whenever pyruvate dehydrogenase complex is inactive. Okay. So the answer is low carbohydrate, high fat diet, choice C. So this question, in a patient who's tall, obese, known to have hypertension and has recently been diagnosed with metabolic syndrome, right? You know, metabolic syndrome is a form of a disorder, right? Wherein there should be 3 out of the 5 criteria that fits into a diagnosis of metabolic syndrome. And it's a sign of insulin resistance. When it's a sign of insulin resistance, insulin levels will be high. Okay, uric acid level will be high. triglyceride level will be high. But what about cholesterol? One of the criteria for metabolic syndrome is that HDL level is low. So total cholesterol need not be always elevated. Just remember, in a patient with metabolic syndrome, total cholesterol might not be high because of the low HDL level that is seen in metabolic syndrome. That is one of the criteria for metabolic syndrome. So just remember, metabolic syndrome is a syndrome which represents insulin resistance. It is all about central obesity. They present with hypertension, right? The abdominal circumference is high. They present with hypertension. They present with low HDL. They present with high triglyceride. Have all these in mind and then read all these choices. Okay. Let's look at choice A. Will they present with increase in uric acid and insulin? Yes. I said insulin resistance, which means there will be high insulin levels. And because of insulin resistance, uric acid cannot get secreted in the renal tubule. That causes high uric acid. So choice A is true. How about choice B? Yes, they present with raised blood pressure, but not normal insulin. Their insulin levels are high. Choice C. Increase in triglyceride, yes. But increase in total cholesterol may or may not be present because HDL level is low. Raised blood sugar and low insulin. Yes, raised blood sugar, but insulin level is high because it's a sign of insulin resistance. Okay. So which is the right answer here? The right answer here is choice A. It is increase in uric acid and increase in insulin. Choice A is the right answer. Okay. This MCQ is about a chronic alcoholic, right? So before we start discussing this MCQ, please remember alcoholism is a form of anabolism. Alcohol provides excess energy without micronutrients. That is why we call alcohol as a source of empty calorie, excess energy, no micronutrients. So a chronic alcoholic is prone to develop multiple micronutrient deficiencies. Have that in mind. Now read this question. A chronic alcoholic patient presents with agitation, confusion, and gait abnormalities. Okay, which vitamin deficiency is most likely responsible for these symptoms? The moment you read this question, you would think of thiamine. But do you see thiamine deficiency among choices? No. Even then, even if there was thiamine deficiency presents with GOA. What does GOA stand for? Global confusion, ophthalmoplegia, and ataxia. Okay, but here you don't see any thiamine among the choices. Now look at what are the other choices. Niacin deficiency. What do you see in the case of niacin deficiency or vitamin D3 deficiency? It presents with 3 Ds of pellagra. What are the 3 Ds? Diarrhea, dermatitis, dementia. Do you see any diarrhea component here? Do you see any dermatitis component here? No. So let's exclude B3 or niacin deficiency. Folate deficiency, yes, is probable in a chronic alcoholic, but folate deficiency presents only with macrocytic anemia. It does not present with neurological manifestations. So it is not folate deficiency. Can it be B12 deficiency? Yes, highly possible given these manifestations. Because B12 deficiency causes neurological manifestations. It starts as peripheral sensory neuropathy, wherein they complain of tingling sensation in the periphery. Then it involves lateral spinothalamic tract, posterior column, and even corticospinal tract. Right? That is when you call it a subacute combined degeneration. So what do you mean by subacute combined degeneration that you see in B12 deficiency? Ascending and descending tracts are affected. Right? Ascending tract meaning posterior column is affected. Descending tract meaning corticospinal tract is affected. So when posterior column is affected, what do they present with? They present with gait disturbances, ataxia. Okay, and then descending tract is affected, cortex is affected. That is why they present with agitation, confusion, gait abnormalities. So what is the right answer here? The right answer here is B12 deficiency. It is subacute combined degeneration. Okay. This MCQ A 16-year-old patient presents with pellagra-like skin eruptions during the spring season for the past 5 years. Lab tests reveal normal levels of 5-HIAA. What does this signify? When you see normal levels of 5-HIAA, it means you can rule out carcinoid syndrome. Okay, carcinoid syndrome can also present with pellagra. Because what is pellagra? Pellagra is niacin deficiency. This niacin comes from tryptophan. Please remember, niacin comes from tryptophan. 60 milligram of tryptophan is equivalent to 1 milligram of niacin. So, one of the causes of niacin deficiency or pellagra is tryptophan deficiency, or whenever tryptophan is not getting converted to niacin. When will tryptophan not get converted to niacin? Whenever tryptophan is used for serotonin synthesis. From tryptophan, you do not only get niacin, you also get serotonin. So, in carcinoid syndrome, whatever tryptophan is available is used for serotonin synthesis. So, tryptophan is not available for niacin synthesis. So, one of the causes of pellagra is carcinoid syndrome. But if it was carcinoid syndrome, 5-HIAA levels should have been high. Because that level is normal, which condition is excluded? Carcinoid syndrome is excluded. Okay, there is high amino aciduria, high urinary indole levels, which means it is Hartnupp's disease. Okay, amino aciduria with high urinary indole level, meaning it is Hartnupp's disease. So, what is Hartnupp's disease? Hartnupp's disease is a neutral amino acid transporter defect. This transporter is present in intestine as well as in the proximal convoluted tubule. And what is the function of this neutral amino acid transporter? It is to cause tryptophan absorption along the small intestine and to cause tryptophan reabsorption along the renal tubule. When this transporter is defective, tryptophan is not getting absorbed into the system. That causes tryptophan deficiency. Without tryptophan, there is no niacin synthesis. That causes 3 Ds of pellagra. So, what is one of the manifestations of Hartnupp's disease? Hartnupp's disease presents with tryptophan deficiency and hence niacin deficiency and hence 3 Ds of pellagra. So, the child presents with diarrhea, dermatitis and dementia. But the same transporter is responsible for tryptophan reabsorption also. When that does not happen, tryptophan will be found in the urine. That causes amino aciduria. Right, that causes amino aciduria and high urinary indole levels. So, whenever you see a child presenting with 3 Ds of pellagra with amino aciduria and high urinary indole levels, then what is your diagnosis? Hartnupp's disease. So, based on the findings that are given in the question, we have ruled out carcinoid tumor. We have ruled out nutritional pellagra. Had it been nutritional pellagra, you should not have seen amino aciduria. Right? And we have excluded essential fructose urea. Essential fructose urea, essential meaning no other findings. Only fructose is found in urine. It is not going to present with dermatitis. Got it? So, what is the right answer here? The right answer here is Hartnupp's disease. When will you suspect Hartnupp's disease? Whenever you see 3 Ds of pellagra to be accompanied by amino aciduria and increased urinary indole levels. Okay? Answer is choice C. This is a very simple question. Which of the following post-translational modifications is common to collagen, hemoglobin and immunoglobulin? So please remember, the question is about post-translational modifications. So what are the choices that you can exclude based on this term? I would exclude poly-A tail addition. Because what is poly-A tail addition? That is post-transcriptional modification. Right? For those of you who don't remember, you know genes on transcription give rise to mRNAs. Please remember, genes on transcription give rise to mRNAs. mRNAs on translation give rise to proteins. Okay, what is a post-transcriptional modification? After mRNA is formed, any modification that happens is called as post-transcriptional modification. That includes poly A tail addition. So this is not post-translational. Let's exclude that. DNA mismatch repair. DNA mismatch repair is one of the DNA repair mechanisms that happen during replication. Right? It happens during replication. It's not post-translational modification. So now we are left with two choices. One is hydroxylation, the other one is subunit aggregation. The answer is subunit aggregation because all these three proteins are multiple subunit proteins. Collagen is a triple helix. It has 3 polypeptide chains. Hemoglobin, it's a tetrapeptide, right? It's not a tetrapeptide, it has got 4 subunits. Alpha 2, beta 2, alpha 2, gamma 2. So 4 polypeptide chains, 4 subunits come and get aggregated for hemoglobin also. Immunoglobulin, 2 heavy chains, 2 light chains. So all these three proteins have what in common? They are all multiple subunit proteins. So during translation or after translation, all these subunits come and get aggregated. So the right answer for this question is subunit aggregation. It is not hydroxylation, because hydroxylation happens only for collagen maturation, not for hemoglobin, not for immunoglobulin. So the right answer here is subunit aggregation, choice B. This is a very simple question again, though it looks like a complex case-based MCQ which has a paragraph question, right? Let's read it. You will be able to answer this. A newborn infant is brought to the clinic with jaundice and a white punctate and scattered opacity in the central lens. The condition is consistent with oil drop cataract. Characteristic phrase. Oil drop cataract is a feature of galactosemia. Do not forget this. Oil drop cataract is a feature of galactosemia. So what is the right answer here? The right answer here is choice C. Okay. Now, if you look at other choices, phenylketonuria, they don't present with cataract. What do you see in phenylketonuria? They present with hypopigmentation, mental retardation, mousy odor. Right? Phenylketonuria, what does it present with? It presents with hypopigmentation. Dull, I can't call it as dull, they are less pigmented, right? And they present with mental retardation and with mousy odor. They don't present with cataract. Maple syrup urine disease, you see burnt sugar odor of urine, right? You don't see cataract here. Wilson's disease, yes, you might see a cataract, which is sunflower cataract, right? Had it been Wilson's disease, you should have seen only sunflower cataract, not oil drop cataract. Hence, the right answer is choice C, which is galactosemia. This is a one-liner. Oxaloacetate is produced from which of the following amino acids? In all our rapid revision sessions, LRR sessions, we have discussed this. Oxaloacetate is obtained from aspartate, right? Aspartate and asparagine give rise to oxaloacetate. And that is why we have a transaminase. Aspartate transaminase is otherwise called as SGOT. Right? Aspartate transaminase is otherwise called as SGOT, which means aspartate on transamination forms oxaloacetate. So oxaloacetate is formed from aspartate and asparagine. Leucine and lysine are purely ketogenic. When I say they are purely ketogenic, I mean to say they form acetyl-CoA. They don't form oxaloacetate. So if they ask you what are the purely ketogenic amino acids, your answer should be lysine and leucine. Alanine forms pyruvate. Right? Alanine forms pyruvate. Alanine does not form oxaloacetate. This is an interesting MCQ. You will have to learn in and out about homocystinuria. Let's read this question. A 62-year-old male with coronary artery disease comes to the physician for a follow-up examination. His blood pressure is normal. One of the risk factors for coronary artery disease is hypertension, but here that is normal. And height. If you look at the height, the person is quite tall. weight normal, BMI is okay. Serum studies show a glucose concentration which is normal. So hyperglycemia, another risk factor, is also ruled out. The person is not obese. And homocysteine concentration is high. Normal is still 15. The homocysteine concentration is high. Please remember, hyperhomocystinemia or homocystinuria can cause coronary atherosclerosis because homocysteine thiolates LDL particles. That makes LDL particle prone to get oxidized. Oxidized LDL is more atherogenic. So one of the causes of atherosclerosis is hyperhomocystinemia or homocystinuria. So now you know this person is presenting with coronary artery disease because of homocystinemia or homocystinuria. Okay. Serum lipid concentrations are within the normal range. So dyslipidemia, another risk factor, is ruled out. Which of the following enzyme deficiencies is most likely to be found in this patient? They are asking you indirectly which is the cause of hyperhomocystinemia or homocystinuria. The answer is cystathionin beta synthase. Cystathionin beta synthase defect causes type 1 homocystinuria. Okay, so let me tell you in short about homocysteine metabolism so that you understand causes of homocystinuria. Okay, so homocysteine, a sulfur containing amino acid, either becomes cysteine or it becomes methionine. Logical, right? A sulfur containing amino acid homocysteine either becomes cysteine or it becomes methionine. The enzyme which converts homocysteine to cysteine is cystathionin beta synthase. The enzyme which converts homocysteine to cysteine is cystathionin beta synthase, which is dependent on vitamin B6. The enzyme which converts homocysteine to methionine is methionine synthase. And this methionine synthase is dependent on B12. To be very specific, it is dependent on methyl B12. This methyl B12 gets its methyl group from methyl tetrahydrofolate. Okay, so tell me, what are the causes of homocystinuria? Homocystinuria is either because of a block in the major fate or a block in the minor fate. It is either because of a defect of cystathionin beta synthase or it is because of a defect of methionine synthase. If it is because of a defect of cystathionin beta synthase, it is called as type 1 homocystinuria. If it's because of methionine synthase defect, that is called as type 2 homocystinuria. So here, among the choices provided, what is the right answer? The right answer is cystathionin beta synthase. Okay. And if you look at other choices, they have got nothing to do with homocysteine elevation. There is no enzyme by this name. Okay. Homogenticate oxidase defect, just now we discussed, causes alkaptonuria. Okay. It has got nothing to do with homocysteine elevation. HGPRTase defect causes Lesch-Nyhan syndrome. Okay, HGPRTase, hypoxanthine guanine phosphoribosyl transferase defect, causes Lesch-Nyhan syndrome, which presents with hyperuricemia. It does not present with hyperhomocystinemia. It presents with hyperuricemia. Okay, so the right answer here is choice B. In which of the following locations can cardiolipin be found? Cardiolipin is diphosphatidylglycerol. Okay, cardiolipin is diphosphatidylglycerol, which is seen in mitochondria. To be very precise, it is seen in the inner mitochondrial membrane. So both cardiolipin and cephalin, are properties of inner mitochondrial membrane, and a defect of cardiolipin synthesis causes Barth syndrome. Right? It causes Barth syndrome. True to its name, when cardiolipin is not synthesized, it presents with cardiomyopathy. It presents with dilated cardiomyopathy and neutropenia. If you know these facts about cardiolipin, that is enough. Cardiolipin is a glycerophospholipid that is present along the inner mitochondrial membrane. A defect of cardiolipin synthesis causes Barth syndrome, which is characterized by dilated cardiomyopathy, heart failure, and neutropenia. So the answer for this question is choice B, inner mitochondrial membrane. Thank you.
Hello everyone. So today I will be discussing the dermatology questions from your Pulse test. Coming to the first question, what is the causative agent responsible for causing acne fulminans among the following options? Now, we all know that acne is caused by overgrowth of microbes like Propionibacterium acnes and Staph epidermidis. Now, amongst the option here, Propionibacterium is there in the option, so that should be the answer. It does not matter what type of acne it is. All type of acne has same pathogenetic mechanisms with some extra factors in some. But the organism remains the same. So there is no confusion here. Even if it is acne fulminans, my causative organism will be Propionibacter acnes. Moving on to the next question. What is the probable diagnosis for a pregnant woman age 30 who visits the OPD with the following condition? And what is the condition that you see here? You see pigmentation on cheeks. So if I have pigmentation on cheeks, no other history, and a history of pregnancy, we know that it is the type of melasma that I see in pregnancy, which is also called as cloasma. So here the answer would be cloasma or melasma in pregnancy. SLE will present with malar rash. Viral infection does not present like this. Rosacea will have erythema, telangiectasias and other things. This is simple pigmentation on cheeks seen in pregnant patients. So this is cloasma. Which of the following does not exhibit the Koebner's phenomena? Koebner's phenomena is of two types, true and false. True Koebner's is seen with lichen planus, psoriasis and vitiligo. And false Koebner's is seen with molluscum contagiosum and warts. So which does not exhibit Koebner's phenomena? Vitiligo, psoriasis and lichen planus does exhibit. Herpes, we do not know of herpes presenting with Koebner's phenomena. So the incorrect option where would be herpes. This is a very important question and a very straightforward question. Identify the type of psoriasis given in the picture. Now we know psoriasis has different morphological forms. So if I look at the picture, what am I seeing? I am seeing small erythematous, mildly scaly or no scaly papules and plaques on trunk. And if I look at it closely, it is giving a characteristic raindrop appearance, right? So this description fits into only one type of psoriasis, which is guttate psoriasis. Guttate psoriasis we know is seen in children, more commonly seen on trunk. The lesions are less scaly as compared to conventional psoriasis. They are erythematous papules and plaques, and they typically appear as raindrop appearance as multiple small erythematous papules which are there on the trunk. Erythrodermic psoriasis will present with erythema and scaling involving more than 90% of body surface area. Pustular psoriasis, you will see visible pustules and lakes of pus. Inverse psoriasis is seen on flexure. So this is a case of guttate psoriasis. Next question. A 40-year-old male presents to the OPD with painful genital ulcers along with painful buboes. He has history of multiple sexual partners. What is the diagnosis? So we are dealing here with STD causes of genital ulcers, and we know that there are 5 main causes. What is the history provided to us? We have painful genital ulcers along with painful buboes. So chancre is out. Chancre is single lesion and it is painless. Donovanosis is out. Again, it is painless. Now, chancroid and herpes are left. Both can present with painful lymphadenopathy, but Herpes would present with vesicles and erosions. It is chancroid which presents with painful genital ulcers, and even the term buboes is used mostly for chancroid. So buboes we use for LGV and chancroid. They are nothing but painful suppurative lymphadenopathy. And the other thing that in the question it is mentioning ulcers, not vesicles and erosions. So here the answer would be chancroid, which is caused by Haemophilus ducreyi. A 7-year-old boy is brought to the pediatric clinic by his parents with complaints of multiple soft pedunculated masses scattered across the torso and limbs. Parents mention the child has recently developed some difficulty in reading and learning. On examination, there are hyperpigmented macules with irregular borders on back, and we have an ocular examination finding shown below. Very, very clear cut case. Here, what are these soft pedunculated masses? These are nothing but neurofibromas. What is this? Difficulty in reading, low intelligence. Hyperpigmented macule is nothing but cafe au lait macules. And what do you see on these? These are leash nodules or iris hematomas. Then what is this a case of? This is clearly a case of neurofibromatosis 1. So this is not tuberous sclerosis. All these features are clearly of neurofibromatosis 1. Neurofibromatosis 2 presents with acoustic schwannomas, does not have all these clinical findings. A 3-year-old child is brought to the clinic with generalized vesicular rash covering the entire body. Parents report that rash started as red spots and then developed into fluid-filled blisters. So initially they were macules and then they went into vesicles. There is fever, there is irritability. And look at the image. This is such a clear-cut image. You see a background of erythema, and on top of it you see vesicles sitting, which is nothing but dewdrop on rose petal appearance. And this is seen with chickenpox or varicella. So this is a case of chickenpox. Chickenpox is also called as varicella. Dewdrops on rose petal appearance, fever, irritability, macules developing into vesicles in a child. It's a very, very clear-cut history for chickenpox or varicella. Shingles is herpes zoster, presents with dermatomal distribution. Smallpox is not seen. Dermatomyositis does not present like this. It presents with Gottman sign and heliotrope rash. The involvement of which of the following results in the given condition seen below? Now, this is a very, very easy question. What do you see? You see unilateral edema of a limb, and most likely it's a non-pitting edema. So, when you have unilateral non-pitting edema of the limb like this is usually an underlying lymphatic issue, and so this would be lymphatics here. Arteries, vein would not present like this. DVT does not present like this. It is the lymphatics which present like this. Most likely it's a case of filariasis. Next question. A 45-year-old patient presents with facial appearance that is marked by thickened, coarse and deeply furrowed skin. Skin appears to involve cheeks, forehead, nose. There is numbness and weakness in the extremities. On examination, you see hypopigmented and erythematous patches with loss of sensation. What is the medical condition characterized by the term leonine facies? So this is the description of leonine facies, lion-like faces, thickened, coarse, deeply furrowed skin. Leonine facies have a lot of deities, but in the question, they are clearly giving you a clue. There is numbness, weakness, there are erythematous, hypopigmented patches with loss of sensation. Now, I've told you multiple times, when you see this, you think only of leprosy. So here, leprosy with leonine facies, this is a description of lepromatous leprosy. Acromegaly can also present with leonine facies, but there will be no loss of sensation. Same with myasthenia gravis and Bell's palsy. So this is a characteristic description of leonine facies seen in lepromatous leprosy. Next question. A 50-year-old patient presents with skin lesions characterized by red scaly patches. Patient also complains of painful and swollen finger joints. On examination, the finger joint appears inflamed, tender to touch. What is the most likely diagnosis? Now, when I see this red scaly patches, I think of psoriasis. And if I look at this looks like sausage digits. Sausage digits with his clinically on cutaneous examination, you are seeing psoriasis, involvement of distal interphalangeal joint. All of this is classical for psoriatic arthritis. So, psoriatic arthritis is very common. Patient usually will have lesions suggestive of psoriasis. You will see sausage digits, you will see involvement of distal interphalangeal joint. All these point towards psoriatic arthritis, right? Thank you so much.
Hello everyone, welcome to this session with me, Dr. Vaishnavi, and we are going to decode all the MCQs that were given for your pulse test for the FMGE examination. So we are going to briefly and comprehensively cover all the important topics in this particular discussion. So let's start with the first question, where they have given you a view where an X-ray beam is projected from the occiput going to the frontal. So occipitofrontal view, you can clearly see the chin is down and the frontal bone or your frontal sinus is touching the X-ray plate. So whenever you have the occipitofrontal view, we know that that view is called as Caldwell's view, and this is the best view for the frontal sinus. So in such questions where there is an image that is talking for itself, you really don't have to go through the question. You can just read the question to reconfirm whatever you're thinking is right. So when they have given you the X-ray that is at a specific angle and they're asking you what is the name of the view, it is very simple. It should not take more than 10 seconds. It is nothing but your Caldwell's view. What is Townie's view, Law's view and Stenver's view? All of these three views are for mastoid. We are not using these views for evaluation of the nose and paranasal sinuses. These all three views are used for evaluation of the mastoid bone to understand if there is any mastoiditis or the disease of the middle ear and that of the mastoid air cells. So clearly we know the occipitofrontal view is nothing but your Caldwell's view, which is the best view for your frontal sinus. For your maxillary sinus, we do the chin up position, which is called as the Waters view. If you do the same occipitomental view with mouth open, then we use it for sphenoid sinus, which is called as your Pierre's view. So these were the views that we use commonly for your sinuses, and the rest three, Townie's, Law's and Schuller's, Stenver's, all of these views are for your mastoid bone. So let's go to the second question. We have an elderly diabetic female who's presenting to you with a black foul smell discharge from the nose, and on examination there's a blackish necrotic mass. So whenever we hear this word black necrotic mass, there's something that strikes to our brain, and we know that for sure it has to be an invasive fungal infection, commonly mucor. But then let's just read the question further. It has eroded the septum and hard palate. So we know mucor is an extremely progressive, rapidly progressive fungal infection that is angio-invasive, invades the blood vessel, causes tissue ischemia, because of which there is necrosis of the tissue, ischemia of the tissue, resulting in erosion. So the probable diagnosis here is nothing but your mucormycosis. Now, why not aspergillosis? Aspergillosis can be of two types, invasive and non-invasive. But the invasive aspergillosis will again not present to you with a blackish necrotic mass. Aspergillus is known for its green color. And second thing, the commonest entity between the two of them is going to be mucor and not aspergillus. So that is why we are going to take it as mucor over aspergillus, and especially if it is immunocompromised, it's mucor. Usually non-invasive fungal sinusitis, we see that it is aspergillus that is most common. Foreign body in an elderly female is not a possibility at all. Rhinosporidiosis will present to you with bleeding rather than any necrotic mass in the nose. So the clear answer here is nothing but your mucormycosis. So let's go to the third question, which is for a patient who is going to require BAHA, which of the following condition is alright? So what is the indication for use of BAHA in a patient is the question. So is it for SNHL, is it for acoustic neuroma, is it for congenital external auditory atresia, or is it for otitis media? So we clearly know that BAHA stands for bone anchored hearing aid, and bone anchored hearing aid is used when your conductive pathway, which means your external ear and middle ear, are not functional. Like say there is any canal atresia, there is anosia, no pinna at all, external auditory canal atresia, or if a patient has a chronically discharging ear and you cannot put a hearing aid, in such patients we put a bone anchored hearing aid where at the squamous temporal bone you put a screw and over that you put the aid, and this will transmit the impulses directly to the cochlea bypassing your external ear and your middle ear. So this is device, bone anchored hearing aid is a device that is used whenever you're thinking of external auditory canal atresia or anosia where hearing aid cannot be used, or if there is a chronic middle ear disease where you cannot use a hearing aid. In such conditions we use BAHA. So the correct answer is congenital external auditory canal atresia. Acoustic neuroma is a tumor of the cerebellopontine region. So at that place, it's not possible for you to have any impulses going from the bone anchored aid if there is a tumor, because that's a retrocochlear pathology pathway. So if you have to do an implant in such patients, you will do an auditory brainstem implant and not a BAHA. For SNHL, generally we will give hearing aid. BAHA has only one indication in SNHL, which is unilateral SNHL, right? So if a patient has unilateral SNHL, the sound impulses will go from the damaged ear to the opposite cochlea. So through the bones of the skull, it is transmitted to the opposite normal cochlea, and from there it will be conducted. So the two conditions which are going to be the shortest best possible answers is SNHL and auditory canal atresia, but an absolute indication is external auditory canal atresia. And in SNHL, because the option does not specify to you unilateral or bilateral, we are not going to choose that as the best answer. We are going to choose external auditory canal atresia as the best answer. Otitis media does not require any hearing aid. Basically, if it ever requires something, is going to be myringotomy with a grommet. Let's go to the next question, where we have a 60-year-old male presenting to you with painless cervical lymphadenopathy. This is very, very, very important feature where you have cervical lymphadenopathy and ear pain. On examination, there is conductive hearing loss with a dull tympanic membrane, and there is decreased mobility of the soft palate. What is the probable diagnosis? So we know this triad where we see typically there is cervical lymphadenopathy, hearing loss in a male who is 60 years old. All of this prompts to us about nasopharyngeal cancer. And whenever there is a 5th nerve involvement, 10th nerve involvement and conductive hearing loss, we think of a triad called as the Trotter's triad. So they have given you immobility of the soft palate, which is indicative of 10th nerve palsy because of the extension of the carcinoma along the foramina of the base of skull. So this is a very typical clinical scenario suggesting to you of nasopharyngeal cancer. Adenoid cystic cancer, of which region is not mentioned, so we are not going to take this as the answer. Juvenile nasopharyngeal angiofibroma is seen in young males in the juvenile age group. They present to you with bleeding rather than lymphadenopathy. And yes, they can have, involvement of cranial nerves, but it's not the 10th nerve. It is 2nd, 3rd, 4th, 5th and 6th nerve that is involved and not the 10th nerve. Quincy's peritonsillar abscess, it has nothing to do with lymphadenopathy, and if it has to be reactive lymphadenopathy. There is no middle ear effusion or there is no ear pain, and if there has to be, it is not going to cause any cranial nerve palsy. So this is the clinical scenario for nasopharyngeal cancer. Which of the following treatment options is not recommended for a 4-year-old boy? Not recommended is asked for a patient who has 4-year-old boy with low-grade fever, inspiratory stridor, barking cough for the past 7 days. Examination shows to you hoarse voice, inflamed pharynx and slightly increased respiratory rate. Chest x-ray showing to you subglottic narrowing. So there are most words that suggest to you croup over here, but some words that could be confusing, that could suggest to you epiglottitis, is your inspiratory stridor. Now again, in croup, which is laryngotracheobronchitis, there can be biphasic stridor, or in the early phase there can be inspiratory stridor. So except for that word, we know that everything else, 4-year-old child, low-grade fever and subglottic narrowing, barking seal-like cough, all of this hoarse voice prompts to you towards the diagnosis of croup. So when you have croup, of course, airway is an emergency. So you're going to give intramuscular dexamethasone, Heliox, which is a mixture of helium and oxygenation, so that the oxygen can penetrate the airway quite easily through the inflamed narrowed airways. And epinephrine is given again to shrink the mucosa so that the edema across the airway will resolve. So these three are the primary line of treatment. Of course, we do give cefotaxime, but that's not the primary treatment. It is a treatment given to prevent secondary infection. So all the 4 options are actually right. But if you had to choose one option which is not used as the preliminary mode of treatment, then that has to be cefotaxime. Let's do the next question. What would be the next step of management of a 7-year-old child who underwent tonsillectomy and now presents to you with snoring, palpitation, mouth breathing and slight hearing loss with a high arched palate, decline in school performance concerning the mother? All these features, snoring, mouth breathing, high arched palate, crowding of teeth, and if there is hearing loss which is indicated to you by decline in school performance, all of that indicate to you adenoid hypertrophy causing middle ear effusion. So this particular clinical scenario is talking to you about adenoiditis, but they have given to you the child has undergone tonsillectomy, not adenoidectomy, right? It could be that the child has undergone tonsillectomy for some other reason. They're just giving that line to confuse you. But the right answer here, where you have a child who has adenoid hypertrophy and hearing loss, you are going to initially give a conservative management of 3 months, but if it does not resolve, then you're going to do an adenoidectomy with Grome. So here they have not mentioned the duration of symptoms, but we particularly presume, because the next step is asked, we would definitely think about doing an adenoidectomy with Grome insertion. Yes. What would be your diagnosis for a patient with a prior history of trauma and is currently experiencing symptoms of double vision, nosebleeds and limited eye movement provided on the CT image? So the CT image is speaking for itself. It is showing to you that there is a fracture of the floor of the orbit, which we call it as blowout fracture. So blowout fracture is something that we see in the image, and this particular fracture happens because of, blunt trauma towards the orbit, and the floor is the weakest part which gives away, and it gives rise to a sign which we call it as the teardrop sign. The inferior rectus and the inferior oblique may get entrapped into it. So now we know the answer is very, very easy and simple, which is blowout fracture. Leaford fracture is the fracture of the maxilla. Zygomatic fracture is called as tripod fracture. A fracture has occurred in the cribriform plate of the ethmoid bone. This can present to you with which symptoms? So we know that if there is a fracture of the cribriform plate, which is the weakest area in the base of the skull, and if there is a fracture, it can result in a dural tear resulting in CSF leak into the nose, which we call it as CSF rhinorrhea. So cribriform plate will obviously lead to CSF rhinorrhea. It has nothing to do with orbit and hearing, so there is not going to be any hearing loss, visual loss or diplopia. Which of the following structures contain Osman's pad of fat? So Osman's pad of fat is the kind of fat that we have towards the nasopharyngeal end of the eustachian tube. So we know eustachian tube connects the nasopharynx with that of the middle ear. So the nasopharyngeal end, where the eustachian tube opens, it is covered by a cushion of fat, a pad of fat, which generally keeps the tube closed. And when the palatal muscles actively open it, the tube opens, allowing the air to enter into the middle ear. So this pad of fat is very important so that there is, maintenance of tone and collapsed eustachian tube. So this Osman's pad of fat is related to eustachian tube. And if there are patients who have sudden weight loss or post-pregnancy, if there is loss of fat, it could result in a condition where the patient will have autophony. They hear their own sounds, which is called as patulous eustachian tube. So this is called as patulous eustachian tube. So Osman's pad of fat is related to eustachian tube. While performing caloric test, what type of nystagmus would you expect on cold water irrigation? This is a simple rule where we have learnt cows. Cold water will cause nystagmus towards the opposite side and warm water will cause nystagmus towards the same side. So the correct answer is cold water to the opposite side. So in caloric test, we use temperature as a stimulant to the labyrinth, and when you use cold water or warm water, the lateral canal in the inner ear gets stimulated to cause nystagmus in the eye. And we use 7 degrees above and below the body temperature to do this test. If we use only cold water to perform the test, we call it as Cobrag's test. If we use both warm and cold water, we call it as Fitzgerald-Halpike test. And instead of water, in those patients who have a perforation of the drum, if we use air, we call it as Dundas grand tube test. So these were a few important points regarding your caloric test. The next question is on a 2-year-old child who's presenting to you with noisy breathing. Which type of stridor is going to be expected in this patient? So the laryngeal picture is representative of an omega-shaped epiglottis. We know this is a case of laryngomalacia. Very, very simple. So in patients with laryngomalacia, you're going to expect inspiratory stridor. So we know that a rule of stridor exists. Any pathologies above the vocal cord will result in inspiratory stridor. Any pathology at the vocal cord and up to the subglottis and cervical trachea will result in biphasic stridor, and any pathology in the mediastinum will result in expiratory stridor. So laryngomalacia, most common congenital anomaly, presents to you with inspiratory stridor. A 30-year-old patient with chronic sinusitis and nasal congestions, which anatomical structure is most likely related for the drainage of pathway of the bulla ethmoidalis? So we know bulla ethmoidalis is the biggest ethmoidal air cell, and we also know that it is an anterior cell. So when an anterior cell drain or an anterior ethmoidal cell drains, we know that they drain into the middle meatus. In the superior meatus, we have the drainage of the posterior ethmoidal cells, and the sphenoid sinus drains into the sphenoethmoidal recess. So the question here is about anterior ethmoidal cell, so that drains into the middle meatus. What is the investigation carried out immediately of a child who is suspected to have inhaled a foreign body? So whenever we've learnt about foreign bodies in the airway, the first step is to do a chest X-ray, X-ray neck and abdomen. If that is not showing to you foreign body, then you go for rigid bronchoscopy. So I hope you got answers to all your questions. Thank you.
Hello friends, we are going to discuss a few very important MCQ for this particular test. My first question is, a 10-year-old boy was brought to the emergency department after consuming some iron tablets. The child is presenting with severe abdominal pain, profuse gastrointestinal bleeding and lethargy. What is the preferred treatment of this case? So it's an iron tablet. So the treatment is deferoxamine. The chelating agent for iron is deferoxamine. British anti-leucite, which is also known as dimercaprol. It is used in all poisoning, but the question comes in exam. It is contraindicated in two poisoning. Ci contraindicated, Ci cadmium and iron. Now, EDTA is used in lead and DMSA is used in lead. Penicillamine is a very important chelating agent for copper and desferoxamine is for iron. So this was the first question of this exam. Gastric lavage is contraindicated in which of the following poisonings? Strychnine, paraldehyde, hydrocarbon and iron tablet. Here the best answer is hydrocarbon. If you see, the absolute contraindication of gastric lavage is corrosive because of thin mucosa, because it causes perforation. The relative contraindication are these, that is C, convulsion in coma, V, volatile poison. Example, like hydrocarbon, like kerosene. That's very important. One hydrocarbon, that is kerosene, because in kerosene there are chances of aspiration. That's why the answer is hydrocarbon. In esophageal varices, it is contraindicated. Pregnancy, it is a relative contraindicated. Now you can see all remaining H, heart disease, hypothermia and hemorrhagic diastasis. These are the relative contraindication, but anyways here answer is hydrocarbon, which is a kerosene. It causes aspiration, that is a relative contraindication. The most common organ involved in seatbelt injury, here the best answer, if you want to ask the particular one, that would be mesentery. But here, apart from mesentery, the second best answer is hollow viscus. You can see the seatbelt injury, the most common organ injured is mesentery. The remaining are small intestine, that's a hollow viscus, spleen and liver. So second best answer would be small intestine, that is a hollow viscus. That's why here answer is hollow viscus. Now friends, this is a question. A 23-year-old farm worker with having a history of snake bite and there is a headache, blood vision, tingling sensation of the mouth, dizziness, vertigo, had a multiple episode of vomiting since the bite. But sir, very important catchy point is respiratory depression and bradycardia. Now, at the local site, there is a mild swelling and blistering, but a very important feature, no apparent bleeding. No apparent bleeding means vascular toxicity or viper is ruled out. He was administered 10 vials of antivenom. what will be the subsequent step of the management? So it is neostigmine with atropine. The reason is these all are the feature of cobra bite, which is a neurotoxic, the allopathy group. And here we give neostigmine, and to counteract the side effect of neostigmine, we also give atropine. The dose of neostigmine is 1.5 milligram and dose of atropine is 0.6 milligram. And why do we give neostigmine? Because neostigmine act on the postsynaptic cleft, the cobra bite act on the same. So it is very important. This is the cobra bite, that is anti-snake venom, neostigmine and mechanical ventilation. V for viper, V for vascular toxic, that's a bleeding manifestation. That's why we give fresh frozen plasma and surgical debridement. But Karate bite doesn't act on the postsynaptic cleft. Karate act on the presynaptic cleft. That's why we don't give neostigmine and atropine. Here only anti-snake venom and mechanical ventilation. So this is a very important question generally been asked about snake poisoning. Now, what is the most appropriate term to describe the behavior of a man who consistently gets sexual pleasure causing physical harm to the partner, means giving pain to the partner, like cuts and burns on their arm? This is sadism. So you can see a few important words. Giving pain to the partner is sadism or algolagnia. Suffering pain from the partner is masochism or passive algolagnia. The combination of sadism and masochism is bondage. The combination of sadism and masochism is bondage. If murder serves as a stimulus for sexual act, it is known as lust murder. If you are satisfied with urine, it is known as urolagnia, undinism or urophilia. But sir, urinism is not related with urine. What is urinism? Urinism is sexual gratification by fingering, licking or sucking. And if you are using fecal matter for sexual satisfaction, fecal we use the word copro, that would be coprophilia. So anyways, giving pain to the partner, it is sadism, and suffering pain from the partner, that is masochism. Passive algolagnia is masochism. And the remaining option, fetishism, is by inanimate object, and voyeurism is watching a nude girl or girl involved in sex. Wo for voyeurism, wo for watching. And fetishism is फटी हुई चीज से मजा लेना, that is by inanimate object if you are satisfied. So here answer is sadism. According to the amendment of MTP Act Bill, that is 2020, what is the permissible age for mentally ill or rape victim that MTP can be done? So here in rape victim, the MTP can be done up to 24 weeks. So here answer is that is mentally ill or for rape victim MTP done up to 24 weeks. Generally for contraceptive failure up to 20 weeks. So consent for MTP is required from the mother, but age of the mother should be more than 18 and mother should be having sound mind. If the age of mother is below 18 or having unsound mind, the consent from legal guardian is required. MTP is generally preferable up to 24 weeks. Yes, in rape cases up to 24 weeks. Up to 20 weeks we require one doctor, and 20 to 24 weeks for MTP we require two doctors. So that is MTP. During the examination of victim of assault, a wound has ragged, irregular and uneven margin. That is a very important catchy point. Uneven, irregular, ragged margin, and the tear diverging at the angle. And if you see, that is forming swallowtail. So what is swallowtail? This is swallowtail. The tear is diverging at an angle. And my dear friend, bleeding is not significant. Bleeding is not much. And we see the crushed blood vessels and crushed hair bulb. What this wound is, very important finding: irregular margin, crushed hair bulb, bleeding is not significant, and swallowtail. All these important findings are suggestive of laceration. It is caused by heavy blunt trauma. It is laceration. As you can see, the laceration, irregular margin, caused by heavy blunt trauma. Here you can see the hair bulb are crushed. The blood vessels and nerve are crushed. And here we have swallowtail, that is tearing at the end angle, that is diverging, that is known as swallowtail. These all are the feature of laceration. Which test is employed to distinguish human blood from blood of other species? Means if you want to distinguish the blood from human to other animal, the test is precipitin test. And it is not only for blood, my dear friend, any bones, hair, semen analysis. If you want to differentiate human from other species, will do precipitin test. Following the death, a 40-year-old male that had a tattoo mark on his body, but upon autopsy, the tattoo mark is not observed. What is the best location to check the presence of tattoo? Because the tattoo, the dye goes to the lymph node level. The best location to check the tattoo and the dye is up to lymph node level. And we also do regional lymph node biopsy. During a forensic autopsy, the next question, a gunshot victim is examined and the doctor observed that the firearm has a stellate shape. So it's very simple. If the shape is stellate, it is a contact shot. Now you can see the difference. In contact shot, the muzzle impression present, this is contact, and the shape of the contact shot is stellate. In all remaining, the shape is circular. Muzzle impression is absent in close shot, near shot, and distant shot all. In contact shot, because the burning, blackening, and tattooing goes inside the tissue, that's why it is absent. In close shot, burning, blackening, and tattooing all are present. In near shot, only blackening and tattooing, because the flame effect disappears. And in distant shot, all are absent. Abrasion and grease color present in all shot. So that is a very, very important. Here the shape is given stellate. That is a contact shot. Now, sir, in forensic investigation, the police recover a beheaded skull bone and receive a photograph of missing person from their relative. And the two sample can be analyzed by which technique? Sir, the skull bone with photograph, we use a superimposition technique. The best method for criminal identification is fingerprint. For decomposed body, DNA fingerprint and examination of lip print cilioscopy. But skull bone and photograph are analyzed with each other. The branch is known as superimposition technique. So here answer is option C. So my dear friend, this was all about the analyzing the important question of the forensic medicine here. So thank you very much. Good luck. Goodbye.
Okay guys, boys and girls, I hope your test went well. So let's dive into these questions, pretty straightforward ones for today. The first question on the screen talks about a patient with sickle cell anemia. He says you are dealing with a patient where hemoglobin is 9 and then is that unmistakable sickle cells present. And as you are aware, in this condition, you have sticky red blood cells. So I want to improve the perfusion. And to improve this perfusion, what I'll do is give blood transfusion to these patients. Unlike in patients with thalassemia, where we prefer giving packed RBCs, here it would be blood transfusion that would be best recommended. The remaining options can be ruled out. I mean that IV antibiotics and D options or weight 10 watch are like dummy ones. And then deferoxamine is given in cases where there would be hemochromatosis. So the answer is B. Moving to the next one, again very classical hardcore general medicine question. Which of the following condition is characterized by absence of P waves? This would be unmistakable atrial fibrillation. Two conditions where we get absence of P waves is one is sick sinus syndrome and second is atrial fibrillation. We get it in hyperkalemia also, but considering that the remaining options in this question are from the tachyarrhythmia perspective, so the answer will be option number D. C is ruled out because there would be undulations from baseline and VT anyway has a broad QRS complex tachycardia. And as far as focal atrial tachycardia is concerned, it would be having premature P waves present. Moving to the next one, we have a guy, he's a smoker and then there's a difficulty in swallowing and then he said what lung cancer can be present. Now this question is deliberately trying to distract you by talking about dysphagia, but then it's a simple straightforward fact. Lung cancers that begin with alphabet S are associated with cigarette smoking and are central location. So our answer in this case would be the unmistakable squamous cell carcinoma. The subsequent question says a diabetic patient with vomiting and abdominal pain. I mean, there has to be one question on the topic of diabetic ketoacidosis. You can see that the sugar value, the random blood sugar of this patient is more than 250. So D part is satisfied.
Then he's also given evidence of ketones, not directly but indirectly by mentioning the sweet breath in a patient. And therefore, since this patient is dealing with, or he has himself mentioned diabetic, so I can say diabetic ketoacidosis is the presentation. And the main thing in this condition is to start IV fluids and then also keep a tab on potassium. And then subsequently, we will be giving insulin drip to this patient after 1 hour. But since he's saying what would be done initially, so it would be IV fluids and checking potassium. In this particular ECG, you will notice that very characteristic ST depression is present. Where I put the arrow, there is presence of hidden P waves, because see, normally you are able to see the T and the P waves separately. Here the P and the T are merging and there's a narrow QRS tachycardia. So the diagnosis in this case will work out to SVT, supraventricular tachycardia. Option number D will have a broad QRS complexes. Ventricular fibrillation will be having a twitching, and atrial fibrillation has an absent P wave, so they can be easily ruled out. Then we had this 50-year-old woman with the skin lesion that is increasing in size, and then he has mentioned about diabetes. He has mentioned regarding deep vein thrombosis. So those D's are trying to come up, and he's asking regarding a pancreatic neuroendocrine tumor, because all the 4 options are from a pancreatic neuroendocrine tumor. The answer in this case is the dermatological diagnosis would be necrolytic migratory erythema. That is a feature that is seen with glucagonoma. And as far as the remaining options are concerned, with gastronoma, we read about peptic ulceration but not a skin lesion. With insulinoma, like there's a Whipple's triad that is usually described, not given in this case. We don't have diabetes in insulinoma. No, that's the point against it, because he mentioned history of diabetes. Only one of them is going to be capable of causing the diabetes manifestation, that is glucagonoma. And as far as option number D is concerned, you can very well remember vasoactive intestinal polypeptide will contribute to rice water stools. That's a pancreatic cholera. The answer here is C. Then we have a chap with productive cough, and the highlight in the PYQ was that it increases on change of posture. That means that there must be very substantially large amount of pus present in the lungs from the reservoir. Like it's literally like a reservoir of pus that is present, and therefore our clinical diagnosis in this case is bronchiectasis. Lung cancer will present with cachexia. Bronchial asthma will present with breathing difficulty, and pulmonary embolism will usually have some risk factors of deep vein thrombosis. But considering that productive cough and change in position contributing to like the increase in the expectoration is the main reason why the answer to this question is bronchiectasis. Then is cat scratch disease, that's called by Bartonella Hensley, pretty straightforward. When it comes to Borrelia burgdorferi, that would be responsible for contributing to relapsing fever. And as far as the next one is concerned, a young male with drooping of eyelids. The only thing is it is a young male, not a female. And he says that the symptoms of the patient are worsening as the day is progressing. And moreover, ice pack test is also given. So this is unmistakably myasthenia gravis. In myasthenia gravis, we have deep tendon reflexes being normal in spite of the muscle weakness. Huntington's chorea will be having chorea. Will also be having dementia, which would be early onset. Amyotrophic lateral sclerosis will be having combination of upper motor neuron as well as lower motor neuron findings, not given in this case. And external ophthalmoplegia, well, that would contribute to ptosis or would also contribute to diplopia. But then the diurnal variation that is given in this question, day progresses, that's how he's described it, will change the entire game, and answer is A. Then is unilateral hypoglossal nerve palsy. The tongue will be protruding to the same side. Normally in CNS, all manifestations are opposite, but the way the tongue muscle fibers are crossed, the tongue deviation would be to the same side. Then we have this long stem question, patient having jaundice. The jaundice is like occurring on a recurrent basis. Like he says that even 2 years ago, the guy had, he was doing a little bit or too much of sports, and following a basketball practice, there was presence of jaundice present. So whenever you get this long stem question where there are recurrent episodes of jaundice, it's unlikely to be like a viral hepatitis. And from the conjugated hyperbilirubinemia variety, the most common variety that you are going to encounter is Gilbert syndrome. Among the remaining ones, if you look at the data, you see serum AST, ALT is normal. That itself is going in favor of Gilbert syndrome, because see, Dubin-Johnson syndrome will be having cholestasis. There would be some component of obstructive jaundice or cholestasis that would be given, where like mainly what will be elevated would be conjugated. But if you check out the report of this guy, it is unconjugated bilirubin that is elevated. So that immediately rules out these two options. And Crigler-Najjar syndrome, like this would be having more of a pediatric type of a presentation and not in adult, and would not be having the recurrent episodes, which is why the answer is C. Then is a patient who is having high blood sugar. She's 19 years of age. She's having type 1 diabetes. He's just telling you knowledge of like which variety of insulin would be used in this case. So it would be regular insulin that we shall be using. Then tall male, lack of pubic hair, underdeveloped genitalia, and then is given the karyotype as well. I mean, you don't need to even look at the karyotyping report that is given. The answer in this case is Klinefelter syndrome. Noonan, the standard question, is associated with pulmonic stenosis. It would be a female who is looking like a Turner syndrome patient but is 46XX. CAH will present with ambiguous genitalia. Vanishing testing, as the name suggestive, I mean, the patient manifestations given in the question don't match with option number A. So the correct answer is B. Legionnaire's disease is caused by Legionella pneumophila. It is an atypical organism, and that is why the antibiotic that we use is azithromycin. In the ABG report, you can notice that this arrow of pH and PCO2 is going in opposite direction, so that immediately tells me it is respiratory acidosis. Even if I don't know it is a metabolic compensation by increase of bicarbonate, normal is 22 to 26, it really doesn't matter. Even in this particular question, you can notice that it is the upgrade of bicarbonate that's happening. So the correct answer here is option number A. Then is ABJ report again, where all the three arrows are going down, down, and down. So this would make it a case of metabolic acidosis. Then is best for long-term control of diabetes mellitus is glycosylated hemoglobin. So these are like pretty straightforward ones, guys. And now we come to one which is slightly tricky. Markedly low reticulocyte count and platelet count is normal. See, aplastic anemia will be having pancytopenia, so all the three things would be going down in that case, whereas he has specifically mentioned that TLC and platelet is normal, so that is the reason why I'm ruling out aplastic anemia. When it comes to hemolytic anemia, the reticulocyte count will be increased, so we are left between two options: iron deficiency anemia and pure red cell aplasia. When it comes to iron deficiency anemia, most of the time the platelet count of the patient may be slightly elevated, and at the same time, when it comes to reticulocyte count, it can be low but not markedly low. Why I'm giving benefit of doubt for the current question as pure red cell aplasia is because of the word markedly low. If this markedly word was not given and platelet count was also given to be, a little on the higher side of normal or slightly elevated, I would have answered it as iron deficiency anemia. So this is the only one where I think that you are having to rack your brains a bit. Otherwise, most of the questions that are given today are in a very easy format. Then is ptosis diplopia, that is worsening with the activity, that is again myasthenia gravis, and tensilon test is positive. He says what is likely to confirm the diagnosis. Now for confirmation, we'll be doing is the antibody test. The antibody test, as I've explained, is one of the most specific tests. So first we do, if we have done a tensilon test, then to be sure, like we just need to demonstrate an antibody because this is an autoimmune basis. I know your mind will be saying, why not single fiber electromyography? So this is a sensitive test, right? This is for diagnosis of the case. This is like in nowadays used in place of tensilon test. But then considering that he's saying confirmation, so I'll just say like in HIV, you read ELISA is positive, then you do a Western blot assay. In a similar sense, here we are doing an antibody based test for diagnosis. So I think these are the only two questions where like you might have to bit struggle. Otherwise, there's like super easy. The next patient is for daytime sleepiness. The ABG is showing a hypoxia. PCO2 is elevated. I mean, awake stage, PCO2 is elevated, I'll straight away say obesity, hypoventilation syndrome. Well, how am I so confident? Because once she is obese, and then you will say, why not obstructive sleep apnea? Then in obstructive sleep apnea, the ABG will not be showing is like this significant level of carbon dioxide present and a substantial amount of hypoxia present. So we'll have to go with obesity, hypoventilation as compared to obstructive sleep apnea in this. Narcolepsy will not have ABG changes. I mean, narcolepsy, the ABG changes would be perfect. ABG levels would be perfectly normal. And considering demonstration of respiratory acidosis, that's why the word Pickwinian syndrome or obesity hypoventilation syndrome is present. Then you can see a sudden onset right-sided hemiparesis that is occurring in this guy. On the left-hand side, there is a bleed. On the right side, there is a weakness. He says, what will you not do in this case except, like, because the except word in this case is present, we will not be doing a thrombolysis. Thrombolysis is contraindicated in a patient of brain hemorrhage. Then is a patient of muffled heart sounds and there would be cardiac tamponade that I'm suspecting. He says, what is the JVP finding? So there would be an impaired ventricular filling. Now, because of the impaired ventricular filling, the Y descent in the JVP of the patient would be absent. So the answer is B. Then is that lady with dry mouth, grittiness, dry eyes, dry mouth. Standard presentation of dental caries is also present. That's because the saliva part is lesser. That makes it Sjogren syndrome. That would be where the exocrine glands are affected. So dry eyes and dry mouth as a presentation is there. Vaginous granulomatosis will always be having ANCA mentioned, C ANCA. And then there's going to be upper respiratory tract vasculitis, lower respiratory and the kidney vasculitis as well. Then is this patient having raised JVP till the mandible. So there's a heart failure that is happening here. And if you look at the next one, calcitonin as a marker of malignancy, that would be medullary carcinoma thyroid. Super easy, man. I mean, I think you should be scoring 100% in the questions that are coming up. We'll increase the difficulty level as the time comes, but at the moment, like, they're super easy. You can look at CTPA report. There is a big clot. He's saying what is done to determine the etiology. Etiology would mean that the cause here was deep vein thrombosis and then the clot dislodged and went to the lungs of the patient. So for the etiology perspective, I'm going to be doing a Doppler. The Doppler is best way to identify deep vein thrombosis in a patient. If he said first test, it was D-dimer assay. The best test for diagnosis CTPA, but to find the etiology, Doppler would be done. Then is a patient with the hematuria. There's a bit of flank pain, RBCs which are present in the urine, and dysmorphic. The moment you read the word dysmorphic RBC, the MCQ is crying out loudly that this is a case of glomerular bleeding. The moment you say the word glomerular bleeding is present, the diagnosis in this case is PASGN, that is post-streptococcal glomerulonephritis. Then we have a chap with history of COPD, hypertension, diabetes, so many problems. So the criteria that we'll use, like Duke's criteria is for infective endocarditis, Light's criteria is for hydrothorax, that is for a pleural effusion, and Jones criteria, that would be for diagnosis of rheumatic fever. So the current case, the diagnosis by exclusion here is Beer's criteria. So this would be a quick summary of the questions that we have discussed, guys, and keep hammering and you're gonna do great when the real crunch time comes. Thank you.
Hi everyone, let us now discuss the questions of microbiology that were asked in the recently conducted Pulse test. The first one was to do with a 68-year-old woman being hospitalized for 3 days for a left leg cellulitis and was treated with clindamycin. 2 days after her discharge, abdominal pain and watery diarrhea happened. So we started off with a different pathology and we've ended up being a GI pathology. Over here they are saying that of course it's an infection because normal total leukocyte count is between 4,000 to 11,000. Over here it is much increased. Along with that, inflammatory markers are increased, ESR and C-reactive protein. So that tells me that whatever disease she had, for that she ended up taking long-term antibiotics. And long-term usage of antibiotics can thereby result in the infection with Clostridium difficile, resulting in PMEC, that is pseudomembranous enterocolitis. Now please note, in microbiology, they will ask you what are the two toxins of Clostridium difficile causing it. It is toxin A and toxin B which result in this disease. Then they will ask you the respective images. If you call it pseudomembranous, then membrane, you can see the dirty yellow membrane, and that is usually seen on the mucosal aspect of the intestine. Along with that, microscopically, you see the classical volcano-like eruption. So basically, the tissue is dying or is becoming necrotic, and that looks like a lava bursting from a volcano. Volcano-like eruption is a very important question for pseudomembranous enterocolitis. Moving on to the next question over here, where we have a patient coming to the gynae OPD with a foul smelling, frothy vaginal discharge and intense itching. I think the buzzword over here with the cervix being strawberry like, you have discovered it to be Trichomonas vaginalis. If an image would have been given, this would have been the red color spots making it strawberry. Sometimes they're not calling it strawberry cervix nowadays, they're calling it angry looking cervix, reason being the red color spots. Now they've asked you which of the following statement is false, and the false one of course is the first one, because we know that Trichomonas vaginalis follows the TTT rule, which means Trichomonas is going to have only one form, and that is trophozoite. It does not have any cyst form, so the cyst form mentioned over here totally becomes false, and the answer over here. And this trophozoite, I've got you a picture just in case they give you a photo. How many nuclei can you see in this trophozoite? I can see one nucleus. And how many flagella can we see? I can see 1, 2, 3, 4. 4 flagella which are going anteriorly, and then there is one long flagella which is going posteriorly. So I can see a total of 5 flagella, and if it's got flagella, then it definitely must be moving. So the motility is also known as the twitching or the jerking motility. Remember, Trichomonas only trophozoite twitching motility. This means everything else is correct. It is an obligate parasite, yes. Then the treatment of choice for the strawberry cervix is going to be metronidazole. Partner treatment is important because this is a sexually transmitted disease. And the gold standard for culture, maybe you've not heard of CPLM, maybe you've heard of the other culture media, like we have read diamond culture media, lash culture media, but CPLM can also be used. So what if you don't know an option in the exam? What are you supposed to do? Pick out the answer that you're very much sure of. Like over here, they asked you the false statement and you're very certain that cyst does not exist. You've anyway got your answer, so give it the benefit of doubt. Moving on to the next question, where you have to get 1 or 2 questions with sterilization. It's a must for microbiology. So they've asked you, how would you sterilize a glass petri dish? And I can see options of autoclave and hot air oven. Ideally, glass can be put in both. But we've always studied that hot air oven is something which is preferred. Now I need to figure out the temperature. I've always studied 160 degrees centigrade for 2 hours. And this is how a hot air oven looks like, which is the answer over here. Now, what if hot air oven was written at this temperature? This is totally wrong. What else can I use? I can also use autoclave. What is the temperature for autoclave? It's 121, 15, 15, which means 121 degrees centigrade, 15 minutes and 15 psi. Psi is the pressure unit, right? Because autoclave looks exactly like just a vertical or a long pressure cooker. It has a whistle on the top. It is actually going to have a sound of a whistle similar to a pressure cooker in your kitchen. So this is going to have a unit of pressure that is 15 psi. I've got my answer of hot air oven, 160 degrees for 2 hours or 120 minutes. Moving on to the next question, which is to do with a patient having fever for 3 days and general fatigue with echo revealing vegetations on the valve, which means this is the case of endocarditis. If they are doing a blood culture, they are thinking of infective endocarditis, probably could be rheumatic heart disease. If we read further, they have found alpha hemolysis on blood agar. This very classically tells me that whenever I'm thinking of alpha hemolytic, we are talking about streptococcus, and that goes well because over here they've given me a native valve. In a native valve, streptococcus infection can occur, and when they're talking about alpha hemolytic, either it is going to be streptococcus viridans or it is going to be streptococcus pneumoniae. Now, pneumoniae causing endocarditis, causing vegetations, of course not making sense. Viridans is something which is known to cause infective endocarditis, but over here I don't see viridans in the options. Viridans is the name of a family. Which bacteria comes under this? Is going to be streptococcus sanguis. Usually through dental procedures this can gain access into the blood, and then it can go via the blood to the heart and cause endocarditis. Further, if you remember, in alpha hemolytic, when you have to differentiate between viridans and pneumoniae, you do 3 testings. We had learned them by the biotesting. Means what? Bile solubility, everything will be yes, yes, yes for pneumonia, which means bile solubility by streptococcus pneumoniae, inulin fermentation by streptococcus pneumoniae, optochin sensitivity by streptococcus pneumoniae. Over here they've written resistant. It is not optochin sensitive. It is not showing bile solubility. Everything is negative, which further goes in favor of the viridans family, which is the answer over here. Let's move on to the next question, where you've got a sample cultured on LJ media. What is the stain for this organism? You might feel, what a simple question. But as I always say, never underestimate anything about TB. LJ media, in fact, was the last year's INI-CET question also. We know it's for TB. You know the photo of LJ media that is asked. It is this greenish looking media. And when TB will grow, it will show the classical rough, buff, tough colonies. And if it's TB, what is the stain that you're going in for? You're going for the acid fast or the ZN stain. Again, we've studied this so many times that ZN stain is going to show you a red color TB organism, and the background is going to be blue in color. That's the classical of ZN stain, which could be an additional question. Well, in these options, I see one more option, which is negative staining. Although that's not related to this topic, but negative stain as a question is very important. It is a stain which is used for cryptococcal meningitis caused by the fungus Cryptococcus neoformans. And give me some examples of negative stain. That is India ink and nigrosin, very famous fungus questions. Moving on to the next, we have infections in humans, which is caused by the ingestion of quadrinucleated cyst. That's the buzzword. And that cyst has come into our body through contaminated food and water. So some fecal-oral route. They've asked you the cause, and that is going to be Entamoeba histolytica. Now, if you remember from the image point of view, Entamoeba histolytica goes in two organs. Ent, of course, intestine. In the intestine, it causes the classical flask-shaped ulcer. But it has the word histolytica. Histo means tissue. Lytica means breakage. It can break any tissue. Like over here, it can break the liver tissue, and that is going to result in this brownish color pus known as the Anker-Sauce appearance. But now, having done the GIT and the liver manifestation, coming back to how do we have this disease, fecal-oral route by contaminated food and water. And in that food and water, what is mixed? It is the quadrinucleated cyst. So quickly, do you want to revise what are the two forms of Entamoeba histolytica? Either it can be a trophozoite form or it can be a cyst form. Trophozoite, you can see it has only one nucleus. Cyst can have anything between 1 to 4 nuclei. 4 makes it quadrinucleated cyst. And this is the form that will get mixed in our food and water and cause infection to us. One more thing, whether you have one nucleus in trophozoite or you have 4 nuclei in cyst, the nuclei always look the same. Can you see there is a dot right in the center? That makes it a classical cartwheel appearance of nucleus, which you see in Entamoeba histolytica. I'm not discussing Giardia lamblia over here because that's another question coming your way shortly. The next question was to do with monkeypox. They've asked you for the diagnostic test. Monkeypox is, of course, a virus, a DNA virus. And for DNA viruses, of course, what is going to be the diagnostic test? It is going to be a polymerase chain reaction. Now, please note that monkeypox is something when you ask about the reservoir, it comes from the rats. But this can reach us through any which way. It can come from the bite or the scratch of an infected animal. It can come after coming in contact with patients. So patients have rash. So if you end up coming in contact with the rash of such a patient, you can acquire monkeypox. It can be through consuming undercooked meat. It can be through mother to child transmission, through sexual transmission, through droplet transmission. So we realize that possibly every route is possible for monkeypox. And of course, for the diagnosis, you are going to go in for PCR, and that was the question over here. Moving on to the next question, which is the most probable diagnosis they've asked you in a farmer having a warty skin lesion on the foot. Now, having a lesion on the foot means the primary site must have been foot, and there must have been some history because he's a farmer, maybe barefoot walking is there. Then they say warty lesion. Wart in dermatology reminds me of verruca. Yes, that is a classical case of chromoblastomycosis because the other name is verrucous dermatitis. Verrucous tells me that the patient will have multiple warty lesions, usually seen in farmers due to barefoot walking, and chromo tells me something colorful. So this shows you the copper penny bodies, which was shown in the picture here. Maybe you didn't zoom in. In the exam, you couldn't zoom in, but there was definitely a brownish round element which you could visualize even without zooming in. The classical copper penny bodies, but they will ask you the other names of copper penny bodies. That is MMS. It is known as the Medler bodies. It is known as the muriform bodies, and it is also referred to as the sclerotic bodies. These are all the other names of copper penny bodies. Moving on to the next question, a must know for the exam. There's a slide given with Gomori methenamine silver stain. Silver, firstly GMS. GMS written will always tell me something to do with fungus. Silver will always tell me that, yeah, it's going to give a black color, and I can see the black color coming up. Further, they've given me everything in the question. Acute angle branching, I immediately knew aspergillus. Septate hyphae, again aspergillus. Whenever they talk about aspergillus, The first alphabet tells me acute angle branching. The next three alphabets tell me that there is going to be septate hyphae. So the hyphae are going to look like this with septate in between, and a 45-degree branching is going to occur. So if you look carefully, there is a 45-degree acute angle branching. What is the opposite of aspergillus? That is going to be mucor. If they would have said 90-degree or wide angle, obtuse angle, or they would have said aseptate, I would have gone for mucor. When would I think of candida? Candida will not show me true hyphae. Candida will show me pseudo hyphae and the classical shish kebab appearance. Next, blastomycosis. We always study B for 8. Blastomycosis shows you figure of 8 appearance. Well, we finished off this question. We can move on to next. A very important and a tricky question where they said penicillin was given to the patient and there is some hyper. If I would have just read random words and tried to solve it fast in 5 seconds, I would have said, oh, it's a drug-related hypersensitivity. I would have thought of type 1 hypersensitivity because drug reactions do come under type 1. Maybe it was an immediate kind of an allergic reaction, but they didn't talk about immediate allergy. They said penicillin has not resulted in allergy, so I don't think it is type 1. It has resulted in autoimmune hemolytic anemia. So it has resulted in the formation of some antibodies, and then that has resulted in RBC breakage. So hemolytic anemia will tell me that the RBCs are being broken down, which basically means autoimmune hemolytic anemia comes under type 2 hypersensitivity reaction. Any immune, whether autoimmune hemolytic anemia or immune thrombocytopenia, all of these are type 2 hypersensitivities, and that is what you should be marking over here. So be very cautious while reading such questions. Moving on to the next one is a 28-year-old woman coming to the complaint or clinic with diarrhea. Okay, there are abdominal cramps, bloating, weight loss. There is recent travel history and cramping that is present. Obviously, drinking some stream water was there. So a classical diarrhea-related history is given here. Physical examination, there is no fever. There is mild tenderness in the right upper quadrant of the abdomen. Till now, when I was thinking everything to do with diarrhea and traveling, and I saw right upper quadrant could be probably to do with the liver, I thought of entamoeba histolytica, but then the stool examination was a game changer, which said trophozoites and cysts with the classical falling leaf motility. Now, if I would have read this word beforehand, the rest of the history becomes irrelevant because falling leaf motility is classically shown by Giardia lamblia. Now in Giardia lamblia, this is also how the stool examination can look like. Motility means it is shown by trophozoites. Now if I had to draw this trophozoite, we call Giardia lamblia as the angry old man of the intestine. A man will have 2 eyes. So how many nuclei does Giardia lamblia have? 2. And then old man will have a beard. How many flagella does it have? It has 4 pairs of flagella, and that is what you have to watch out for, which means it has a total of 8 flagella, and that flagella has resulted in the falling leaf motility. How did we learn it? Girta hua leaf, falling leaf motility. And of course the treatment over here is also going to be metronidazole that you have to give to the patient, or even tinidazole can be given. Moving on to the next question over here, something that has been coming touchwood since the past many years in every FMG exam, where a 30-year-old patient comes with a skin infection, but the microscopic examination of that sample, what will be written will be the giveaway. Pencil-shaped appearance, and we know this is a case of trichophyton. How did I analyze? So either the image will be given or it will be written. Like over here it was written, but they might also give you an image. So whenever they give you an image, these are the 3 organisms they will talk about. And we learn them as telegram mnemonic, right? Remember the short form of telegram is TME. So trichophyton, microsporum, epidermophyton, and to differentiate them, I will look at their big ones, that is the macroconidia ones I will look at, number 1. Then I will look at the small conidia, the dots also over here, that is the microconidia. Firstly, if I talk about the microconidia in TME, it goes in the decreasing order, which means trichophyton is going to have the maximum small microconidia. Then microsporum will have little fewer, and epidermophyton, I don't see any small microconidia over here. Then I will see on the basis of macroconidia, which is learnt as PSC. That is how I said telegram TME and then my telegram channel PSC. That is the name of my telegram channel. So PSC means that trichophyton, the macroconidia, will be like this. Let's mark it, pencil shaped, which was written in the question, and that is why this is my answer. In microsporum, it is going to be spindle shaped as written above, and in epidermophyton, it is going to be club shaped. So remember TME, PSC, and your question is solved. Moving on to the next question, where we have a 10-year-old child coming to the pediatric clinic with joint pain, swelling, and difficulty in walking. There is a tender swollen knee joint and a recent history of sore throat. Reminds me immediately of streptococcus. I do ASO levels and the ASO titers are going to be elevated. Now, renal biopsy is performed and there are glomerular changes consistent with PSG, and I wish I would have read this line first. Now they've asked you which is the organism most likely responsible for both. You realize that this question goes through so many layers, but if you read the last line, you anyway know that both rheumatic fever and PSGN are caused by Streptococcus pyogenes, which is what we did a similar question on right now. Remember? Group A beta hemolytic Streptococcus. Now, one more thing you need to understand, that whenever this patient will have sore throat, always remember that from sore throat to the journey of having cola color urine, which I told you right now, is very often asked. It is 10 to 14 days, which is 2 weeks, and that could be a question. If I look at the other options, if I say group A beta hemolytic streptococcus is Streptococcus pyogenes, then group B beta hemolytic streptococcus is Streptococcus agalacti, and remember gala time in the camp, so Streptococcus agalacti is camp test positive. Well, Streptococcus pneumoniae, the bio-positive ones that I've already discussed, this comes under alpha hemolysis. Moving on to the next and the last question, again an FMG favorite, where you've got a 45-year-old man coming with fever, headache, photophobia and neck rigidity, going more in favor of a meningitis history. He undergone a heart transplant 1 year back and is on immunomodulatory drugs. Okay, on microscopy is where the buzzword starts. There is a differential motility. What is the difference? It is not moving at a high temperature of 37 but is moving at a lower temperature of 25 degrees. That's the classical listeria, which has 3 buzzwords. Number 1, differential motility. Differential means at different temperatures it will either move or not move. Next, whenever it's moving, the kind of motility is known as the tumbling motility. And last buzzword is cold enrichment. Cold enrichment means that whenever it will grow, it will try to grow at colder temperatures like a 4 degree or a temperature of the fridge, refrigerator. So 4 degrees centigrade, if you want to grow it, so 4 degree. If it has to grow, it will grow more in frozen and refrigerated food. For example, there could be a history of consumption of cheese because that is very often stored in the fridge. So yes, 4 degree cold enrichment is also something they would want to give you. And yes, listeria is the answer, which is known to cause meningitis. Well, with that, we wrap up the microbiology questions also. I hope pathology and microbiology were doable in the Pulse exam, and I hope your preparation for the upcoming FMG exam is going well. Wishing you all the very best for your preparation, guys. Hi everyone. I hope all of you performed well in the recently conducted Pulse exam, and now let's discuss the questions of pathology that were asked in this test. The very first one is a very important topic from General Path, and that is to do with nets, and it was asked all of the following are correct about nets except. Now these are the words which you often tend to miss in the exam, and those are silly mistakes which you don't want to do. So what is nets? It stands for neutrophil extracellular traps, and that is how we abbreviated it as nets. The word tells us that the cell in question will always be a neutrophil, as you can see over here. Neutrophil is now going to send all of its nuclear chromatin extracellularly. So you can see all the nucleus initially, which was compact, is now sent extracellularly, and that is going to go and trap any organism, be it a bacteria, virus, parasite. Thereby it will help in killing. So number 1, is it going to be useful when there is severe infection in my body, that is sepsis? Yes, it is useful. Secondly, which is the amino acid that is needed for this nucleus to disintegrate and go extracellularly? Arginine is needed. Now, while this is a very useful technique, can it have certain side effects? Yes, and that is SLE. Because at the end of the day, it is the nucleus which is going outside. So if the nuclear antigen is going out, my body starts making anti-nuclear antibody in certain cases, and that can result, of course, in SLE. So the only situation which is not correct over here is phagocytosis, because we know phagocytosis will always happen inside the cell. So that is also a kind of killing of the bacteria, but that is intracellular killing. On the other hand, neutrophil extracellular traps is going to be killing that will happen outside the cell. So question 1 is done. Let's move on to question 2, which was again a very important and a sure shot topic for the exam, where you have with X-ray of a middle-aged man showing multiple lytic lesions. Now, whenever they say middle-aged to elderly with multiple lytic lesions, always think of multiple myeloma, which is a cancer of the plasma cells. We know plasma cells make a lot of antibodies, and you know that the most common immunoglobulin that increases in multiple myeloma is IgG, and that was the question asked. But is it multiple myeloma? Because if immunoglobulins are increasing so much, then of course those immunoglobulins will start coming out into the urine, and yes, in the urine examination, examination, they have mentioned something called Bence-Jones proteins. Now, what is that Bence-Jones proteins? It is actually when I'm saying that the immunoglobulin G, which is the most common one to rise, it is not the entire immunoglobulin, including heavy chain and light chain, that is increasing. It is predominantly an increase in the light chains that happens. And when those light chains start coming out into the urine, it is known as the Bence-Jones proteinuria. Now, please note that what is that cancer in which IgM levels are going to be increased, and the name of that is going to be Waldenstrom's macroglobulinemia. This is also a type of a plasma cell disorder, but the name tells me macroglobulinemia. So of course that antibody is going to increase in which there is maximum molecular weight, and that is IgM. Let's move on to question number 3 over here, where we have a female patient who's come to us with fatigue and a history of piles. So it's definitely piles or hemorrhoids means that there would be some blood loss happening. Now with that, fatigue is happening, so anemia comes to my mind. I do a CBC and definitely anemia is confirmed with HB of 8.5. Here they've given an MCV of 65 femtoliters. We know the normal MCV is between 80 to 100. If the MCV is 65 femtoliters, it is decreased. I am talking about microcytic anemia. Further, if I think of my mnemonic for microcytic hypochromic anemia, it is Sita or Sheetal. That is how we learn it. They have further written that the RBC count is 3.2 million, which is on the lower side, something very classically seen in our country in iron deficiency. And then they've written that the RDW is increased. Now RDW, what is that normal value that you have to know? It is between 11.5 to 14.5%. And secondly, RDW tells me variation in size of red blood cells. Now that means the RDW over here is increased. This means there is a variation. Some of the RBCs are small, very small. Some of them are slightly bigger. Some of them are normal. So now I realize a variation will always occur when there is a nutritional deficiency, right? This further goes in favor of iron deficiency. Then they've given a peripheral smear over here. Now in this peripheral smear, if you zoom into it and see, whenever you get a peripheral smear, always spot the lymphocyte. This is the nucleus of the lymphocyte, because normally a red blood cell and a nucleus of a small lymphocyte, they are supposed to be the same 7 micron range. They are supposed to look the same. But if I look over here, if this is a lymphocyte, now compare the red blood cell. Don't the red blood cells look smaller? And if they are looking definitely smaller, because I'm dealing with a case of microcytic anemia. Now over here I can also see some different shapes that are coming up, and this means that there is a variation in shape also happening, something classically seen again in iron deficiency. In fact, not very clearly seen in this picture, but iron deficiency can show you a different shape, and that is known as the pencil cells RBCs, which are very commonly seen. So now all in all, if I go back, they've asked me what would you do next, and for iron deficiency I would want to check the iron levels. Iron level study mentioned over here is ferritin levels. Ferritin of course is the storage form of iron. Whenever they give you microcytic hypochromic anemia, I told you think of Sheetal or Sita as a mnemonic, where of course iron deficiency anemia and T for thalassemia are the two things coming to your mind first. Apart from that, there is sideroblastic anemia, there is lead poisoning which indirectly causes sideroblastic anemia only, and then there is anemia of chronic disease. If I have to differentiate between iron deficiency anemia and thalassemia, because both of them happen to be microcytic hypochromic, I will be going in for the Menzer index. What is Menzer index? The first alphabet and the last alphabet that I've highlighted. So that is MCV upon RBC. We have studied that if it is more than 13, I will think of iron deficiency anemia, and if it is thalassemia, if it is less than 13, I will think of thalassemia. And which thalassemia are we talking about? Beta thalassemia trait. But I'm again and again saying that I will think of this. Why am I not certain? Because for being certain, I will have to do hemoglobin electrophoresis. Thalassemia trait would be certain if the HbA2 levels will come out to be more than 3.5%. That is when I'll be able to confirm beta thalassemia trait. Another parameter that I can use, right now I told you red cell distribution width, which will tell me the variation. Iron deficiency anemia is a nutritional anemia. So I will see a variation in the red blood cells. This means in iron deficiency anemia, RDW will be increased. But thalassemia is a genetic problem. Genetic problem means RBCs will always be be small and of the same size. They will not have variation. This means over here the RDW is going to be normal. Now this is your go-to table for differentiation between these two anemias, which will help you in the exam. Moving on to the next question, where you have a 45-year-old patient coming with a history of a chronic inflammatory condition, and that has resulted in something to do with anemia, fatigue, pallor. Lab investigations have shown microcytic hypochromic anemia. So out of the Sita or Sheetal mnemonic, chronic inflammatory tells me anemia of chronic disease, and that has affected the iron metabolism. So they've asked you which is the cytokine responsible, and answer is interleukin 6. I hope you know, whenever we are dealing with chronic diseases, like let's assume they would have given you a chronic disease like rheumatoid arthritis, which is their favorite chronic disease in the exam. These chronic diseases release interleukin 6. Now what does interleukin 6 do? It goes and acts on the liver, and liver then releases one of the most you can call this master regulator, and that is hepcidin. So this is a master regulator of what? It is a master regulator of iron metabolism. So obviously the word hep tells me that it is coming from which organ of our body? It is coming from hepatic system, the liver. And then in tells me that this is going to be inhibitory. It will inhibit the absorption of iron. It will not let us do anything to do with iron metabolism. It will not let you absorb iron, so it inhibits iron absorption. It will not let you release iron from your stores. Your iron is stored in ferritin, right? So it will not even let you use that storage iron. It will not let you absorb the iron that you're eating, and that is why we call it a mastermind, a master regulator, because it has hijacked your entire system. And this is what is released in case of chronic disease under the influence of interleukin 6. That is why over here they say that whenever you want to do the treatment of anemia of chronic disease, it is not iron tablets that I'm going to give to the patient. I'm going to treat the underlying cause, because if you treat it, then the entire pathway is anyway corrected. Moving on to the next question, where you have which of the following is associated with hexanucleotide repeat. Guys, this is a previous year FMG question, and this was a question where you didn't have to know hexanucleotide repeats as a topic, but you had to rule out. When I talk about Fragile X syndrome, these are all mentioned to be trinucleotide. Like Fragile X syndrome is 3 nucleotides which are repeated, which is CGG nucleotide repeat. When I talk about Huntington disease, everyone remembers hunting in a cage. So that is again 3 nucleotides, trinucleotides, CAG repeats. When I talk about myotonic dystrophy, it is going to be CTG repeats that is happening. So these are all trinucleotide. Automatically, what becomes a 6 nucleotide or hexanucleotide is frontotemporal dementia. Do I have to know the hexanucleotide that is repeating in this? No. But when such a question comes in the exam, I need to be very calm and composed and rule out options to come to an answer. Moving on to the next question, where we have a 55-year-old man found to have hepatomegaly on physical examination, complains of having dark skin, tan skin, despite avoiding skin exposure. His liver microscopy is shown, and in the liver you can see they've given you a different stain which is giving a very bluish color. Now try to correlate liver with a blue color stain and a pigmentation in the skin. Out of all of these options, definitely goes in favor of hemochromatosis. That is going to be an iron overload. So for iron, which blue color stain must have been used? The pearls of Prussian blue must have been used. You know, they always want to ask you either the triad of hemochromatosis, iron overload, or they want to ask you the genetics. So what is the genetics? It is HFE gene. We study it is a hereditary hemochromatosis, FE for iron. So HFE gene, and the chromosome is also important, that is chromosome number 6. Now, whenever there is an iron overload, that iron will go to the liver, and that is why they've done a liver biopsy here. You can see the size of the liver has increased. It can also result in cirrhosis of the liver. Secondly, it will go to the skin, and you can see this dark tan color that has occurred, which is classically described as bronze discoloration. Now, iron is not only responsible for this discoloration. While you might feel that, oh, this is iron overload, iron is going onto the skin, so that is resulting in bronze discoloration. It is actually an increased production of melanin. Of course, iron has some role, but melanin is more responsible for this bronze discoloration. Next, iron takes a route towards pancreas, and you know pancreas, if insulin is going to be hampered, this is going to result in diabetes mellitus. That is why hemochromatosis is also known as the bronze diabetes. Now I have a small homework for you from a test. I'm asking you another test. That is, I have 2-3 more things written over here. I want you to mention in the comments of the YouTube video, and let me know that in Wilson disease, which is a copper overload, overload, what is the gene and chromosome affected? And in alpha-1 antitrypsin deficiency, what is the gene and chromosome affected? So you have to tell me the genes and chromosomes of both. I will be looking out for these answers, and if you make an error, I'll correct you, but I know you guys know this very well because these are previous year questions. Moving on to the next one is that in the WHO grading of astrocytoma, so we've come to brain tumors, they've asked you where does glioblastoma fall? Now I've given you a very simple trick for learning this. Any blastoma tumor asked in the brain, glioblastoma, medulloblastoma, pinealoblastoma, is a bomb blast in the brain, which means it's going to be really bad, and the worst grade that you can think of is grade 4. But now let's revise from our rapid revision and main videos that what is the grading that I have to know. For brain tumors, it is the Saint and Mayo grading that is followed. Even if you don't know the name, that is okay, but you should know there are 4 grades, 1, 2, 3, 4. And what is the basis on which the grading is done? It is done on 4 things that you can see over here. Number 1, you will look at how bad are the cells looking, atypia. Next, you will be thinking about how is it proliferating, mitosis, how is it dividing. Third is how much are the blood vessels proliferating. Lining of blood vessel is endothelial cells, so endothelial proliferation. Last is necrosis. So even if you remember the short form, you will know that, okay, these are the 4 things. Now when nothing is present, if everything is absent, no atypia, mitosis, endothelial necrosis, it is going to be grade 1. If only atypia is present, it is going to be grade 2. If atypia and mitosis is present, then that is going to be grade 3. And if 3 or all of the 4 are present, which means out of these 4, if any 3 out of the 4 or more are present, then that is going to fall under grade 4. Repeating once again, AMEN, these are the 4 parameters I have to look at. When nothing is there, it is grade 1. When only atypia is there, grade 2. When atypia and mitosis is there, it is grade 3. And when out of all of these 4, if at least 3 are also met, it is grade 4, which is common sense that grade 1 will have the best prognosis, and as you will proceed towards grade 4, it is going to have the worst prognosis, and that is glioblastoma. Well, this test had another question on glioblastoma, which was clinical based, a 45-year-old patient with headaches and seizures and neurological deficit. There is a mass with necrosis. You can see necrosis meant high grade, grade 4 tumor. And biopsy confirms a malignant tumor. So obviously on the basis of this, I will think of glioblastoma. And these are the 2 images of glioblastoma that they ask you. Number 1, this is also known as the butterfly glioma because this will cross the midline. You can see it is seen on the left side and the right side of the brain. So because it is crossing the midline, it is looking like a butterfly. Secondly, because they mentioned necrosis on imaging, how does that look under the microscope? So you can see that there is some dead pink material, but that is wavy like a snake. And that is known as serpentine necrosis. As I said, it's a grade 4 tumor, so of course the prognosis is going to be bad. Moving on to the next question, where I again feel there were 2 questions of hepatitis which we gave you in this test because one of them is definitely going to come. Here you have a healthcare worker seropositive for surface antigen, also for the E antigen, which is the pre-core antigen, and also anti-HBC IgM, which makes a case of acute hepatitis. I will give you the entire protocol for this also right in the next question. But as of now, they have mentioned that the liver biopsy in such cases will show all of the following except, and the answer over here is ground glass hepatocytes, because the question clearly says that this is a case of acute hepatitis B, and we know that ground glass hepatocytes are a feature which are seen in chronic hepatitis B. Now what is ground glass hepatocytes? Let's first understand the same. If this is a normal liver cell which looks very pink, you know why normal liver cell looks very pink? Because it has a lot of mitochondria. But when it is infected with hepatitis B chronically, it tends to start looking pale like the image over here, and that is known as ground glass. This in turn is because of the accumulation of the surface antigen, that is HBS antigen, which is usually in the endoplasmic reticulum. Now please note that this is a feature of chronicity, and this will not be seen in acute hepatitis. So that means, should you be knowing every feature of acute hepatitis? No, the most important feature that you should be knowing for acute hepatitis is ballooning change. So if I have to tell you that one word for acute hepatitis, remember ballooning change. One word for chronic hepatitis, that is going to be ground glass hepatocytes. Moving on to the next question, where I will be able to teach you the diagnosis in case of hepatitis B. Here again they mentioned surface antigen positive and IgM anti-HBC antibodies positive, and this becomes a case of acute hepatitis hepatitis, how do we decide that? In acute hepatitis, firstly, you will have the surface antigen positive because that's the first marker to rise in hepatitis B. Next, you will have HBe antigen. HBe is said to be the pre-core antigen, and this is also a marker of infectivity. So whenever this antigen is positive, we will say that the patient right now is highly infective. Please note, in the previous question, when they had mentioned HBe is positive, they had clearly also written that there is high infectivity which is correlating. The next thing is that we will see one antibody, and that antibody is the IgM type of anti-HBc antibody. Now, why am I seeing antigens of everything but antibody of the core antigen? Because core antigen as such does not come out in the blood. It will never be positive in the blood. But the antibody of this anti-HBc, IgM type, will be positive, and because it's IgM, that makes it acute hepatitis. On the other hand, if the same surface antigen would have been positive, the same E antigen would have been positive, but now for the core antigen, if the antibody formed is IgG, this makes it a case of chronic hepatitis. Here it was IgM, I marked acute hepatitis. Now let's move on to the next question, where they've said which of the following intestinal pathologies is associated with dermatitis herpetiformis, and we know it is celiac disease. I hope you remember celiac disease is the gluten sensitivity disease, right? And we all know, no need to write, but gluten is present in the bro cereal, that is barley, rye, oats and wheat. This usually occurs due to HLA DQ2 and DQ8 polymorphism, and the antibodies that are formed against gluten usually happen to be the IgA type of antibodies. Please note, these IgA antibodies can now go and attack, of course they will go and attack the GIT. That is why we have this entire story about celiac disease. But this IgA antibody will also go and attack the skin, and that is why it is responsible for dermatitis herpetiformis. Please note, for celiac disease we had learnt DDDD, which means that the patient is going to come to you with diarrhea after consuming either barley, rye, oat or wheat. This is maximally going to affect which part of the GIT, that is duodenum. So of course duodenum is the place where iron gets absorbed. Iron would not be absorbed, patient will have iron deficiency anemia. The same disease can be associated with skin disorder, that is dermatitis herpetiformis, and for the treatment of dermatitis herpetiformis, we have dapsone, and that is how we had learned celiac disease. There was one more question in this test on celiac disease, that what diet is not advised in celiac disease or celiac sprue or gluten sprue, that means the same. So of course, as I said, this is to do with barley, rye, oat and wheat. So these four cereals, of course, have to be stopped from the diet. So that is why the answer, what is not advised, wheat would not be advised. Let's move on to the next question. Like always, one Vacutainer question has to come. Diabetic patient, there's a Vacutainer which you can see is a gray Vacutainer, and gray Vacutainer will always have sodium fluoride. Whenever they give me a gray Vacutainer, of course, they want to test for glucose. And sodium fluoride that you're talking about, that is an additive. Why are you adding an additive? So that you can inhibit glycolysis. You don't want all the sugar should be used. I mean, if all the sugar is used up, what will you measure? So you have to inhibit glycolysis by adding sodium fluoride. But first step is to not let the blood clot. And as an anticoagulant, you are adding potassium oxalate. So potassium oxalate is the anticoagulant and sodium fluoride is the additive added in this. Every test of glucose is done in the gray Vacutainer, be it fasting blood sugar or random blood sugar or postprandial blood sugar. But please note, when you're talking about the 3-monthly levels, 3-monthly control, glycated hemoglobin, in this you're just not testing glucose but also hemoglobin. So hemoglobin testing is not done in gray Vacutainer. That is going to be done in the purple or the lavender color Vacutainer, which is going to contain EDTA as the anticoagulant. Moving on to the next question, which was rather a general common sense question, as I would say it. A 28-year-old woman, known case of beta thalassemia, undergoes blood transfusion. Because she's undergoing blood transfusion, I'm obviously assuming she's a case of beta thalassemia major. Let's say that after transfusion or during transfusion, there is anxiety, hypotension and fever. What is the next thing that you would be doing? The first thing will always be to stop the blood transfusion irrespective of whatever symptom the person is having. Stopping the blood transfusion has to be priority so that then you can investigate and find out what's happening. Then of course you will do all the paperwork that is needed. You will check everything required. You will stabilize the patient and thereafter you can restart blood transfusion. So I don't think this required any knowledge. This was was more of a common sense question given to you. Should you continue with blood transfusion when the patient is having hypotension and fever? No. Should you investigate for clerical errors? Yes, I have to. Although nowadays it's very rare that something like this would happen in a blood bank, but I would not immediately start. First, I will have to stop the transfusion, stabilize my patient, then look for all of this. Next, should you straight away administer corticosteroids? Of course not. Without knowing what is the reason, you can't start like this. So option A is the answer. Coming on to the next question, which was more of a dermapath correlation, where they've asked you for type 2 lepra reaction, which hypersensitivity is there. So we know lepra reactions are of two types, type 1 lepra reaction and type 2 lepra reaction. Now over here, of course, these are associated with usually sometimes with treatment of leprosy, sometimes without, but these are usually seen around leprosy treatment, and they are of two types. As I said, type 1 and type 2. If you have to know the hypersensitivities, you have to complete the rule of 5. Means that when you're confused that which one was which hypersensitivity, the total should come out to be 5. So if you're talking about type 1 lepra reaction, then of course the type of hypersensitivity should be 4, because that is how my rule will be accomplished. If they are asking you type 2 lepra reaction, then the type of hypersensitivity should be 3, because then my rule of 5 would be accomplished. So then of course for type 2, it is type 3 hypersensitivity. Do you know the other name of type 3 hypersensitivity? It is also known as erythema nodosum leprosum. Moving on to the next question, all are features of irreversible injury except. Now over here, I can see the first one, that is bleb formation. Bleb formation means what? That if this is a cell and now the cytoplasm has started making some outpouchings like this. Why would that happen? When a lot of water is entering into the cell to accommodate the water. This was seen in the first slide of pathology. That is reversible injury. This is a feature of reversible injury, not a feature of irreversible injury. All the others are definitely features of irreversible. Like amorphous densities. You know amorphous densities are what? They are going to be calcium that is getting deposited in the mitochondria. That is seen in irreversible injury. Further, if the nucleus is breaking, like there is pycnosis or there is karyolysis, anything out of PKK, that is pycnosis, karyorrhexis, karyolysis, that is also irreversible injury. Moving on to the next question, what is the most likely diagnosis in a child, 9-year-old boy with hematuria, hypertension, facial puffiness? A classical, with blood coming out into the urine, with hypertension happening. Of course, I'm dealing with the nephritic syndrome that you have to know. And there's a recent history of throat infection. Throat infection reminds me of sore throat, streptococcus. And of course, with that cola color urine mentioned, I am talking about GABS. GABS is group A beta hemolytic streptococcus. So that is written as GABS. And that is of course streptococcus pyogenes, where of course there will be first throat infection. And within 10 to 14 days, you can roughly write 2 weeks, the patient will start having cola color urine. So what are the other things that they can ask you with? What disease am I talking about? Post-streptococcal glomerulonephritis. Cola color urine is one, but other 3 buzzwords: grossly the kidney shows a flea-bitten appearance. On immunofluorescence, there is starry sky appearance. And on electron microscopy, you can see there are subepithelial humps. What does that mean? That means that these are foot processes. Subepithelium means something below them. Below them, something is going to come and sit, and that is why we call it below the epithelium, below the foot process. Subepithelial humps are noted. Moving on to the next question, where you have the diagnosis being asked in an 18-year-old male with gum bleeding, fever, pallor. Hemoglobin has dropped to 3 gram, which is very low. The TLC has also gone down to 1500. Normal white blood cell count is 4000 to 11,000. So TLC has definitely gone down. Look at the platelet count, only 15,000, because the normal platelet count is 1.5 to 4 lakhs. Now lakhs is normal, we are talking in 15,000. Hemoglobin is also low. Look at the reticulocyte count, that has also gone to the lowermost side. I am talking about now that I will have to see what happened in the bone marrow. That RBC, WBC, platelet, everything has stopped forming, and the bone marrow is number 1 showing lack of megakaryocytes, which means megakaryocyte is the precursor of what? This is a precursor of platelet. The precursor is only not there. That is why I can see the platelet is not forming. Plus the bone marrow is now having a lot of fatty streaks in it, which tells me it is a classical case of acquired aplastic anemia. See, if it would have been hereditary, probably they would have given me a younger age group. This is acquired, could be related to certain poisonings or could be related to certain drugs. But they probably right now don't even know the reason for it. Aplastic anemia tells me that full bone marrow is going to shut down, like RBC, WBC, platelet. Why is this not a case of paroxysmal nocturnal hemoglobinuria? Because that we of course know. See, PNH, what you learn as CD55, CD59, that can also result in aplastic anemia, but right now I don't have any feature of PNH mentioned. Do I have nighttime red color urine? Not mentioned. Next, TB, I don't have any granuloma written over here. Next, myelodysplastic syndrome, can this also result in aplastic anemia? Yes. But myelodysplastic dysplasia will mean some precancerous or cancerous looking cells. And over here they have mentioned there are no immature cells. There are no cancerous looking cells mentioned here. So I will not even think of myelodysplastic syndrome. Moving on to the next question is, a boy was diagnosed with a medical condition that has been passed down from his grandmother to his father and now to him. Firstly, they've asked you the inheritance. If I just look at the gender bias, is there any gender bias? Because there's a female having the disease, and then there are two males having the disease. So there is no gender bias. And every generation is having, from grandparents to parents to now to the current generation. That makes it a case of autosomal dominant. Please note, in autosomal word tells me that this will happen in every gender. It's nothing to do with gender. Dominant will tell me that this will happen in every generation. Yes, if they would have said that, okay, it's no gender bias, but generations are being skipped. After the grandmother, it has straight away come to the grandchild. The father is normal. If skipping would have been there, I would have thought of autosomal recessive. On the other hand, if they would have said a gender bias, that only the males are having the disease, females are carriers, but disease is happening only in the males, I will think of XLR. And if they give me the classical DDD, that is the dad is giving the disease only to the daughters, I will think of X-linked dominant. I've taken this up very quickly because recently in the rapid revision reignite classes, we discussed all pedigree charts, right? Moving on to the last question of pathology, which of the following cell is responsible for graft rejection? Graft rejection is of so many types, like the hyperacute graft rejection, which tends to occur within 48 hours. That is actually because of antibodies. That is nothing to do with cells. Acute and chronic graft rejections can be to do with cells. Like chronic graft rejection is definitely to do with cells. Acute graft rejection is of two types. It can be to do with cells. It can be to do with antibodies also. So you call it humoral graft rejection. Now, whether acute or chronic, they didn't tell me that. They just said graft rejection. Whether acute or chronic, the cells that will be involved in graft rejection will be the T cells, the T lymphocytes, which is the answer over here. Well, with that, we finished the pathology questions, which were 20 in number, and I hope you were able to get these correct in the exam.
Hello friends, let's have a look at the solutions to the questions of obs and gynae from the pulse test. So the first question, there's a contraceptive image that is shown to you and you are asked that this contains which of the following agents, right? So this is today vaginal contraceptive. Right? So if you have looked at the image from the rapid revision videos and from the main videos also, this today is a vaginal contraceptive sponge, right? So this is like this. You can see in the image here. Okay. So this is a barrier method. Okay, used by the female, and it is to be introduced inside the vagina and kept in place there. Okay, before sexual intercourse, it is inserted and it is kept in place there, and it is designed in a manner that it will fit over the cervix. So that is how it is going to create a barrier, okay, for the ascent of the sperms. Now, this contraceptive sponge is pre-coated. It is pre-coated with spermicidal jelly or spermicidal agent, okay, and that spermicidal agent is non-oxynol 9. So that is your answer, okay. Which of the following is the IUCD with the longest lifespan? Okay, so intrauterine copper containing device, they're asking you longest lifespan, right? So Progesta CERT has a lifespan of only 1 year and it's not even used anymore. But Progesta CERT contains progesterone. It is not an intrauterine copper containing device. Anyways, that's not your answer. Okay, Mirena is progesterone containing intrauterine device. It is not intrauterine copper device. Okay, so that is also not the answer. And if you look at the lifespan of Mirena, if you look at the contraceptive efficacy of Mirena, contraceptive efficacy or contraceptive lifespan of Mirena, that's 5 years. Okay, so these two are out, both are progesterone containing intrauterine devices. Now copper T380A, we know it has a lifespan of how much? 10 years, a contraceptive efficacy of 10 years. So copper T380A is your answer. Okay, Nova T has a contraceptive lifespan of about 5 years. Okay, so this is not the answer, and this is a straightforward one-liner question. A 28-year-old woman complained of inability to conceive. So we have the context of infertility, dysmenorrhea and pelvic pain. Okay, infertility, dysmenorrhea and pelvic pain. She has a history of frequent episodes of PID. So that is your clue here. Okay, now HSG shows absence of peritoneal spillage on the right side. Okay, so on one side they are saying there is peritoneal spillage of the dye is not seen. They may have said free spill of dye is not seen on one side. That means with the side where free spill of dye is not seen, that side the tube is blocked. Right? So tubal blockage, infertility because of tubal blockage, and the most common cause in our country, yes, pelvic inflammatory disease. So the diagnosis is tubal blockage. That is your answer. Okay. Now bilateral hydrosalpinx, you may have gotten confused, but if they are bilateral hydrosalpinx, then they will tell you that the tubes are dilated on both sides, and there is no spill of dye coming from both the sides, right? So the description would have been slightly different. Okay, so it's not bilateral hydrosalpinx. That's why that is not the answer. Okay, so don't get confused. The answer here will be tubal block, right? And endometriosis does not cause tubal blockage, no? So there will not be any tubal blockage in endometriosis, right? The tubes are functionally impaired in case of endometriosis, not actually anatomically blocked. Keep that in mind. And Asherman syndrome means uterine synechia. Okay, uterine synechia. So filling defects inside the uterine cavity will be there. Okay, so Asherman syndrome is also not the answer. Answer here is tubal block. Identify the condition in the image given below. So such sort of image-based questions have previously been asked in FMG many times, right? So you can see here what is the location of the placenta. Can you identify? It is in the lower uterine segment. Also what you are seeing here is that it is here, as you can see, it is completely covering the os. Can you see here? It is here completely covering the os. Right? So this is placenta previa. Okay. So now we have this newer system of defining placenta previa. I mean the type 1, type 2, type 3, type 4, that classification of placenta previa you need to still remember, but that in clinical practice we have simplified things. Let's remember it like that, right? So previa would mean that there is placenta. Of course, it is in the lower uterine segment, but it is partially or completely covering the os. So basically, from the previous classification, if you compare the major degree, right, the 3 and 4, all right, and then we have also, remember, extra point, low-lying placenta. Low-lying placenta meaning that the placenta is in the lower uterine segment, okay, and the edge of placenta. Now, the edge of placenta could be anterior, posteriorly, laterally, anywhere, okay. So, edge of placenta is within 2 centimeters. Very, very important. This is also a question that has been asked. Within 2 centimeters of internal os, that is low-lying placenta. So, please remember here, whether it is placenta previa, whether it is low-lying placenta, there is no vaginal delivery, okay. Even with low-lying placenta, The management is cesarean section, delivery is by cesarean section, and even with placenta previa, which is partially or completely covering the os, that is fairly obvious that delivery is going to be by cesarean section. Let's look at the other options also. Vasa previa, placenta accreta, abruptio placenta. You know that abruptio placenta is premature separation of placenta that is in the normal location, okay, that is in the upper segment. It is not in the lower segment. So with abruption, it is in the upper segment. Placenta in the upper segment is there, okay. Now what about vasa previa and placenta accreta? Let's just have a look at these images also. So this image on the right here is showing vasa previa. Okay. Now, sometimes, please understand that vasa previa can also be associated with low-lying placenta, placenta previa. Here in this image, what we are seeing is placenta is in the upper segment only. Okay. In this image, placenta is in the upper segment only, but it could be in the lower segment also. So what is the clue? You can see here fetal vessels in front of the presenting part. Vasa previa, vessels in front of the presenting part. Okay. Please remember, not umbilical cord in front of the presenting part. Umbilical cord in front of the presenting part is cord presentation. Don't get confused, okay? So, vasa previa meaning that these fetal vessels which are traveling in the membranes, and these are naked fetal vessels. Remember it like that. These fetal vessels are not inside the umbilical cord. Okay, naked fetal vessels traveling in the membranes in front of the presenting part. This is a very dangerous situation. Why? Because when this woman, let's say for example, goes into labor, right? When the lower segment forms, right? When the cervix dilates, or when the membrane ruptures, these naked fetal vessels are also prone to rupture, and then vaginal bleeding happens. But this vaginal bleeding is going to be fetal bleeding. It is fetal blood loss. So it is very dangerous for the baby. There's sudden fetal distress, and this is a very life-threatening situation for the baby. Okay. Now, image on the left. This is what we say placenta accreta. Okay, so placenta accreta syndrome basically, right, which is morbidly adherent placenta, okay. Nowadays we call it placenta accrete syndrome, also call it placenta accrete syndrome. So what happens here is that this is normal. This one here is normal. You can see the decidua basalis. Okay, so if such image is given to you, you can identify the decidua basalis is absent, it is defective, the Nita bush layer is absent, it is defective, and you can see here the placenta is just attached to the myometrium. So A, accreta, just attached to the myometrium. Okay, it is penetrating deeper. Here it is increta. As you can see here that this has gone inside the myometrium, attached further inside the myometrium, so increta. And this is percreta. Percreta meaning it has perforated the myometrium. Okay, so perforated meaning it may have reached the serosa, perforated the uterine serosa, or even perforated the nearby organs there, right? So if there is a bladder in front like that, for example, then it may have perforated, reached the bladder also. That depends, okay, how much it has perforated. But it has perforated the myometrium completely, that is percreta. Out of these, the most common type is placenta accreta, then increta, then least common is percreta. Another image I want to show you is this. Look at this. This is a hysterectomy specimen, and we can see that the placenta is still inside and it is adherent to the myometrium. It has not been able to separate. So that is the most important point with morbidly adherent placenta, that the placenta either it is going to fail to separate completely, or it will separate in bits and pieces. Some places it will separate, some places it may not separate. So it can lead to extensive bleeding and postpartum hemorrhage. Okay. So many times they have asked you this point in your exams as question pointers also. Like for example, they may say that a woman delivered and maybe she has a history of previous cesarean section, which is a very, very important clue, right? History of previous cesarean section clue may be there. Placenta has not separated. Then during manual removal of placenta, the plane of placental separation, the cleavage plane of placental separation is not found. Or they may say that cesarean section was being done and placenta is being separated, and placenta is now separating in bits and pieces, and it is leading to extensive bleeding. What is the diagnosis? It is morbidly adherent placenta. Okay, so when they are asking questions about morbidly adherent placenta, it could be an image-based question or it could be a scenario-based question. All right. What is the use of the instrument given below? So this instrument, okay, is used for hysterosalpingography. It is specially designed for that purpose. Okay, so you can see here, this is the Leach-Wilkinson's cannula. This is the Leach-Wilkinson's cannula, right? So this end here has got serrations and it fits inside the cervical canal. Okay, we don't have to insert it like too deep inside. Let's suppose this is the external loss, this is the internal loss. So we kind of introduce it like this, rotate it, introduce it, okay, and lodge this end inside the endocervical canal, fit it tightly, snugly fit, okay. And then via this end, we introduce the dye, we push the dye, the radio-opaque dye. Then this dye enters into the uterine cavity. Can you see here like this? This is the way it is fitted, okay. And this dye is going to fill the inside of the uterine cavity, and then it is going to come out of the fallopian tubes and spill into the peritoneal cavity. That is how HSG, hysterosalpingography, is performed. And this instrument, that is Leach-Wilkinson's cannula, it is used for that purpose, not for myomectomy, not for endometrial biopsy, and not for conization of the cervix also. Okay. Now keep in mind, very, very important point, that hysterosalpingography is a screening test for tubal patency. Okay. Also keep in mind that the timing for this test is post-menstrual, after the periods are over. Okay, so it can be done anytime between day 5 to day 11 basically. Okay, why we have chosen day 5? Because bleeding has stopped. Okay, I don't want to, do this procedure during the day she's having period bleeding. Okay, so please keep that in mind. And between day 5 to day 11, anytime we can do. Generally in clinical practice, we like to call on day 10 just for convention purpose, but it can be anytime between day 5 to day 11. By post-menstrual also, it would mean that it is done in which phase of the cycle? It is done during the follicular phase of the cycle, or they may say it is done in the proliferative phase of the cycle. It means the same thing. Also remember that HSG is going to be contraindicated. What are the contraindications? Like I said, I don't want to do when there is bleeding. So active bleeding is a very important contraindication. Okay, any genital tract infection that is untreated, we can treat the infection and then perform it if we want. But if there is active genital tract infection, active bleeding, if there is dye allergy, contrast allergy, remember these 3 important absolute contraindications for HSG. All right. A 23-year-old woman presents with 8 weeks of gestation following a positive UPT. She is not willing to continue the pregnancy. What is the appropriate dosage of misoprostol? Okay, so they've asked this question again and again. They're asking about medical method of MTP. Please remember that when we're talking about medical method of MTP and we're talking about first trimester, please remember that the government of India allows it till 9 weeks of gestation. First of all, that point, right? Now, till this 9 weeks of gestation, the drug of choice, if they ask you, is mifepristone plus misoprostol, right? So, mifepristone is 200 milligram oral and misoprostol is 800 micrograms, and this is given 48 hours later. Misoprostol is given 48 hours later. The dose of misoprostol is 800 micrograms. So that is your answer. The route can be sublingual, it can be vaginal, it can be buccal, it can also be oral. Okay, so keep that in mind. Now, so 800 microgram is the dose. Also remember, when we're talking about second trimester MTP, when we're talking about second trimester MTP and we're talking about medical method of second trimester MTP, then also the drug of choice is mife plus meso. Okay, so for MTP, please remember mife and meso is the better drug of choice. Okay. And also remember that misoprostol alone can be given. Mifepristone alone is not recommended. So it's either the combination of the two, in which we give mifepristone first, followed by misoprostol 48 hours later, or we can also give misoprostol alone. So misoprostol alone can also be given. But in the second trimester, the dose of misoprostol is less. Now, in second trimester, it is 400 micrograms every 3 hours for a maximum of 5 doses. Every 3 to 4 hours for a maximum of 5 doses in 24 hours. Okay, so this is from the Government of India guidelines. All right. A young woman experiencing amenorrhea, previous history of DNC for abortion, that is your biggest clue. Okay, so this is secondary amenorrhea, obviously, because she's had an abortion. She's, obviously had her periods earlier also. And a current FSH value of 6 MIU per ml. Now, 6 MIU per ml is normal range. The normal range of FSH is very wide, 5 to 20 MIU per ml. Okay, even if you didn't know the normal range, I would say DNC for abortion, second amenorrhea, these clues are good enough. What is the potential cause for given manifestation? So the answer is Asherman syndrome, right? So repeated, DNCs, multiple DNCs in the past maybe have been done for abortion. Also, please remember that especially when the DNC or the curettage is done postpartum, then the risk of Asherman syndrome is significantly increased. So keep that in mind, especially if curettage is done postpartum. Other than that, genital tuberculosis can also lead to Asherman syndrome as well. Okay, so the problem is with the uterine lining. Nothing is wrong with the hormone production here. Nothing is wrong with the pituitary, hypothalamus, ovaries here. Problem is with the uterus. So why would the hormone levels be abnormal? So hormone levels will be normal. FSH would be normal. Estrogen levels would be normal. So hormone levels would be normal. So the answer here is Asherman syndrome, which happens when there is uterine synechia, scarring of the uterine lining, and that is why amenorrhea. Sheehan syndrome is pituitary necrosis that happens postpartum. So FSH is going to be low. There's deficiency of FSH because there is anterior pituitary necrosis in Sheehan syndrome. And that happens because of postpartum, acute postpartum massive blood loss. So massive PPH clinical profile is generally there. With premature ovarian failure, if there is ovarian failure, meaning there is estrogen deficiency, and because of estrogen deficiency, FSH levels are elevated. Okay, so that is not fitting here. And PCOS patients, they can also present with secondary amenorrhea. Yes, they can. But PCOS patients, please remember the clinical profile is different, right? Young woman with history of abnormal or irregular cycles since the time of puberty, hyperandrogenism, right? Maybe raised testosterone levels. So it could be biochemical androgen excess, or it could be clinical evidence of hirsutism, some evidence of polycystic ovaries on ultrasound. So the profile is entirely different. So that is not the answer here. So this is again an often repeated questions, right? So keep that in mind. What is the probable diagnosis for a 23-year-old woman pregnant for the first time, 34 weeks gestation, she is in her third trimester, right upper quadrant pain, they could have said epigastric pain also, nausea and vomiting, blood pressure is fine, heart rate is fine, generalized swelling is there, but your biggest clues in the question, hemolysis and peripheral smear, you can see TLC is slightly on the higher side. Platelet count is 62,000, less than 1 lakh. So, low platelet. Hematocrit is also okay. Raised liver enzymes. Right? So, what do we see here? Hemolysis, elevated liver enzymes and low platelets. Right? So, hemolysis, elevated liver enzymes, low platelets and upper quadrant pain, right? So, this is going in favor of HELP syndrome. This is HELP syndrome. The confusion that you may have had in this question is blood pressure. Okay, so BP mostly will be on the higher side because it is a severe type of preeclampsia only, right? So, BP can be normal in 15% cases. BP can be normal in 15% cases also. Please keep that in mind. So, that would have confused you. But still, it is HELP syndrome. Okay. Hepatitis B is not the answer. Okay, they have because the jaundice in hepatitis B is going to be very, very marked. So when there is hepatitis, let's just go through it. When there is hepatitis, there is marked jaundice. Okay, there is marked jaundice. So the bilirubin levels are usually more than 10 gram per deciliter. Okay, the liver enzymes, AST, ALT, they are also in thousands. They are raised, very highly raised. Okay, but that is not mentioned in the question here. And in hepatitis, now this becomes also medicine correlation is also there. See, in hepatitis, hemolysis is not going to be there, right? And low platelets is also very unlikely if it's just hepatitis. All right, so keep that in mind as well. And what about the other option? Acute fatty liver of pregnancy. Acute fatty liver of pregnancy is very, very rare. It will look very similar to HELP. Okay, it will look very similar to HELP syndrome, or it will look very similar to severe preeclampsia. That means it is confusing. It will be primigravida, right? And in the third trimester, right? With maybe high blood pressure is also there, right? Edema is also there, right? Proteinuria may also be there. Like elevated liver enzymes are also there, jaundice may also be there. So, it will look very similar to HELP or severe preeclampsia, but how will the diagnosis be different? See, there is going to be liver failure. This is acute liver failure which is pregnancy related. Acute liver failure. So, if you see signs and symptoms of acute liver failure, if they are mentioning hepatic encephalopathy, features of encephalopathy, if they are mentioning hepatic encephalopathy, also if they are mentioning hyperammonemia, okay, markedly deranged coagulation profile, and that is because of hypoprothrombemia. See, liver is the one responsible for producing prothrombin, right? And if liver is failing, then the production of these procoagulants, right, that is affected. So hypoprothrombemia, markedly deranged coagulation profile, right? So if you see this, then it is acute fatty liver of pregnancy. It is also associated with shrunken liver. So these are some of the key pointers. Now, what about obstetric cholestasis? This is not obstetric cholestasis. Obstetric cholestasis also presents in the third trimester only, but jaundice is not the typical feature. Jaundice can happen, but the main complaint is that of pruritus. Main complaint is that of pruritus, itching, generalized itching all over body involving the palms and the soles. Also, keep that in mind. And please remember that the jaundice can happen. Jaundice can happen in about 10% cases, and even if it occurs, it is usually mild. Okay, the serum bilirubin levels don't go beyond 5 gram per deciliter. So jaundice can happen, but it is generally mild, right? AST and ALT enzymes are elevated, usually about in the range of 200s to 250s, generally not more than that. And the important thing is diagnosis is made by elevated serum bile acids. So if serum bile acids elevated, then we make the diagnosis of obstetric cholestasis, right? Until what time after delivery can an intrauterine contraceptive device or IUCD be inserted postpartum? Okay, so again, this is often being asked. So postpartum, it can be introduced within 48 hours. If we don't introduce it within 48 hours, then after 6 weeks postpartum. Then after 6 weeks postpartum. Okay, also remember, especially in the Government of India program also, copper T is being promoted a lot. Okay, so post-placental, this is a little distinct or a little different from postpartum. Okay, so post-placental copper T insertion can be done within 10 minutes of placental expulsion. Okay, so remember it like this. We have an opportunity of introducing copper T in the labor room, right? Post-placental, right then and there. Placenta delivers within 10 minutes of placental delivery. If we miss that opportunity, then the next opportunity will come before discharging the patient from the ward. So before discharging, but within 48 hours postpartum, we can introduce. Okay, but then no longer in the labor room, no longer post-placental, it will become postpartum. So it will happen from the ward, maybe the next day after delivery, but within 48 hours. Okay, and if 48 hours window is also missed, then after that, 6 weeks later, when she comes for a postnatal visit, that will be a time when we will get the opportunity of introducing copper T, of course, if the woman wants to. According to the current ACOG and WHO recommendations, in which of the following scenarios is early cord clamping indicated? So please remember that delayed is the norm. Delayed cord clamping is the norm. It is recommended for all vigorous babies, all babies who are born and they are vigorous. Okay, vigorous meaning you've read in pediatrics. Okay, they are crying and they are pink and they are moving, right, moving their limbs and everything. So nothing is wrong with their Apgar score basically. So for all vigorous baby, irrespective of birth weight, it doesn't matter what their birth weight is, it doesn't matter what their period of gestation, at which period of gestation it is, whether they are preterm or term, as long as they are vigorous, it is recommended that delayed cord clamping should be done. So normal term vaginal delivery, yes. Preterm delivery, yes. And even Rh negative woman, okay, delayed cord clamping is done. According to WHO and ACOG, even in HIV positive women, delayed cord clamping can be done. But understand commonsensically that if the woman is, let's say for example, having severe bleeding, okay, So we have delivered the baby, placenta is still inside, and in that moment she is bleeding very heavily. Right. Now understand here that if you're going to follow delayed cord clamping, we're allowing the woman to keep bleeding. Right. The placental circulation is anyways not intact because of the severe maternal hemorrhage. Okay. And we know that the bleeding, maternal bleeding, will stop only when the placenta is expelled and the uterus contracts. So what I'm going to do? I'm going to do that, early cord clamping and then immediate removal of the placenta because woman is bleeding. And the other indication of early cord clamping is when the baby is asphyxiated. Right? Other is, so one is severe maternal hemorrhage. That is your answer here. The other indication for early cord clamping, other indication here for early cord clamping is asphyxiated baby, or there's a baby in need of resuscitation. So you want to go for early cord clamping and hand over the baby to the pediatrician for resuscitation. Right? So these are the two valid indications for early cord clamping that you need to remember. What is the most effective approach to managing mild nausea and vomiting in pregnancy? So they are asking mild. So that is very usual, that is very common. So we begin with dietary advice. We begin with dietary modification. Eating small frequent meals, avoiding the foods that cause nausea and vomiting in the woman. For most, this would be the most effective approach. If by chance we need to give drugs, then the drug of choice, so the first line drug that we can use is pyridoxine plus doxylamine. Okay, it comes under the trade name doxinate. This is what we often prescribe. Domperidone we don't use. Okay, and fluid intake advice, having adequate fluid intake advice is obviously given to the pregnant woman, right? But that is not going to relieve her nausea or vomiting. Okay, and metoclopramide, drugs like metoclopramide, drugs like ondansetron, they can be used, but if the first line treatment strategies are not working. Okay. According to Government of India guidelines, what is the minimum number of antenatal visits recommended during pregnancy? Straightforward question, minimum 4 visits are there. From WHO, according to WHO, it is 8 contacts. 8 contacts with healthcare provider. But from Government of India, it is 4 visits. Medical termination of pregnancy for the indication of contraceptive failure can be done up to 20 weeks is your answer. Not 24, only 20 weeks. So please remember here, the husband or partner consent is not needed. Okay, please remember it is the patient's consent. Patient's consent, that is most important. Also remember, a patient, the woman, should be at least 18 years adult to give a valid consent. If minor or of unsound mind, then consent is taken from the guardian. Okay. For failure of contraception, like I told you, it is allowed till 20 weeks only for woman and her partner. Also remember that it is allowed on the whole till 24 weeks. So this is from the MTP Amendment Act of 2021. Okay, so many questions are asked on this, right? So please remember, it is allowed till 24 weeks only in exceptional circumstances like survivors of rape or incest and the other indications as mentioned. Also remember, if substantial fetal anomalies are there and the patient happens to be beyond 24 weeks, this is the only situation where the upper limit of 24 weeks can be, we can cross the upper limit also. Okay, upper limit can be crossed or upper limit can be disregarded, but only on approval by a medical board. So the medical board will consist of the gynecologist, the pediatrician, the radiologist also. So there's going to be a medical board which is going to say that okay, it is fine, she is beyond 24 weeks, but one can proceed with the MTP. But that is only and only in this situations, no other situation. Keep that in mind. Also remember that it is not required to record the sex of the abortus. and no other documentation other than admission register needs to be maintained, and records are preserved for 5 years from the date of the last entry. These are certain important pointers regarding the MTP Amendment Act, and please do not forget that till 20 weeks, one registered medical practitioner opinion is needed, and between 20 to 24 weeks, 2 registered medical practitioners opinion is needed. There is only one situation where one can go beyond 24, when there is substantial fetal anomalies and the medical board will say yes on approval of the medical board only. Also remember that till 20 weeks, for failure of contraception, it is only till 20 weeks that it is allowed for this particular indication. A 34-year-old G2P1 at 41 weeks gestation, she is in active labor. She has history of gestational diabetes, previous baby weighed 4.2 kg. So, history of gestational diabetes also there in this pregnancy. Previous pregnancy also, baby birth weight was more, macrosomia history in prior pregnancy, all risk factors are there, right? Fetal head delivers normally, but afterward, despite gentle traction, the shoulders fail to deliver. And there's another sign in which the head recedes back onto the maternal perineum, that is called as the turtle sign. Head recedes back onto the maternal perineum. So what is the most likely diagnosis? It's not CPD. If it's cephalopelvic disproportion, then the head will also not deliver. No. And occipito-posterior position, no, the head has already delivered and it's not occipito-posterior position. They are typically talking about shoulder dystocia, and that's your answer. And this is obviously not right. It is not breech presentation at all, right? A 26-year-old woman presents to primary care physician and she desires to become pregnant in the next few months. So basically, she's planning for pregnancy. She's not taking any medicine or supplements and she wants to know what she should take before conception. So she's asking you for preconceptional counseling and which vitamin is given to prevent the neural tube defect. That is the most important line in the question. Okay, so which vitamin is given? Folic acid is given periconceptionally. Periconceptionally, meaning at least 1 month prior to conception and till the first 3 months of pregnancy. Right, so that is why periconceptional, right? Also, please note that the usual dose is 400 micrograms per day. 400 micrograms per day. Also remember, the dose is increased to 4 milligram per day. Increased dosages are given for those who have history of previous neural tube defect affected fetus. Also note if there is a woman who is on anti-epileptic drugs. Also note that woman with sickle cell disease. Sickle cell disease. These are the 3 most important situations where increased dose is given. I will put maternal diabetes, type 2 diabetes, overt diabetes, maternal diabetes 4th in the list. Okay, some people are giving higher doses maternal diabetes and some guidelines are saying usual dosage is also enough. So this is controversial, but above 3 indications, definitely increased doses given. A 28-year-old Gravida 1 has been pushing for 2 hours with minimal progression. Obstetrician is considered outlet forceps assistant. See, what is the question? They have given you a story. The question is, fetal head is visible at the vaginal opening. If the fetal head or the fetal scalp is visible at the vaginal opening, it means that head is on the perineum. So, outlet forceps are applied. So, outlet forceps are applied when the head is on the perineum. That is your answer. Head 1/5 palpable per abdomen would mean just the fact that the head is engaged. Okay, and I will not use outlet forceps here, because we want more than engage. We want the station that is +3 or more. The head is on the perineum, the scalp is visible. That type of forceps application is called as outlet forceps application. The forceps that are applied at station +2, they are called as low forceps application. And we are not using any instrumental delivery at +1 or 0 station. So, high forceps application, mid forceps application, we are not doing. In which of the following conditions is tandem radiotherapy commonly used? Even if you didn't know tandem, okay, then please remember that for ovarian cancer, it's surgery or chemo. right? With choriocarcinoma, it is also chemo. With endometrial cancer, it is mainly surgery followed by chemoradiation if required. Okay, so commonly used, I would say, would be cervical cancer as the answer. Better answer is cervical cancer when they're especially mentioning tandem radiotherapy. Tandems and colpostats basically. Tandems are there, vaginal colpostats are there, right? These are basically devices, like this is the cancer here, and these are basically devices that are introduced inside the vaginal canal, right? And these are loaded with the radioactive therapy. Okay, so keep that, or radioactive isotope is there. Okay, and from these tandems of vaginal colpostats or these devices, the radiotherapy is delivered to the target tissue. So it is for cervical cancer, I would say, commonly used. Now look at this question. They're asking you, what is the ideal time for umbilical cord clamping after birth? Ideal time. So there's no need to rush for the cord clamping. Early cord clamping is not routine. What are we routinely doing for all rigorous babies, irrespective of their birth weight? Delayed cord clamping, right? And they are mentioning that, no? So 39 weeks gestation, the good muscle tone is there in the newborn, breathing is spontaneous, normal skin color is there, right? So basically it is a vigorous baby. So no need to go for early cord clamping. And what is the definition of delayed cord clamping? I have taught you. Delayed cord clamping simply means not before 1 minute. So we can go for 1 minute, we can go for 2 minutes, we can also go for 3 minutes. We can go for delayed cord clamping till the cord pulsation ceases also. But generally, studies have shown that there is no benefit of delaying beyond 3 minutes. So I would say yes, best answer between 1 to 3 minutes after birth. Which maneuver is performed when the fetal scalp is visible at the vulva as shown? So this is basically a cephalic presentation and the baby is delivering. You can see vertex is delivering. So what is this maneuver? This is the Ridzen maneuver. Okay, this is Ridzen maneuver. It is done when the fetal scalp is visible. It helps to deliver the head by controlled extension. Okay, so we control the extension of the head in the sense that we don't want it to extend too much also. Okay, isn't it? We don't want it to extend too much also, right? And at the same time, we are guarding the perineum as well. So you can see here, this hand at the perineum is sort of lifting the chin also. So head delivery by extension, that is how the head delivers, right? But we also want to support the delivery of the head. We don't want too much extension also. Controlled delivery of the head by extension. Controlled delivery of the head by extension is done. And the original Ridzen maneuver said that it has to be done in between contractions, right? Now there's also what we also modified. There's a modified Ridzen maneuver which many of us follow, in which we are doing with contraction, right? Now the goal of this Ridzen maneuver is, when it was originally performed, the goal is to guard the perineum also simultaneously, right? So the goal was that, okay, the perineal injury will be avoided, the delivery of the head would be much faster, expedited, and like that, right? So Ridzen maneuver is the answer for this question. Just after delivery, the position of the uterus corresponds to the level of how many weeks? So just after delivery, what is the position of the uterus? The fundus is just below the umbilicus. Okay, so just below umbilicus is at 24 weeks. So just below the umbilicus would be 20 to 22 weeks also. So best answer to choose here would be 20 weeks. Best answer to choose here would be 20 weeks, and that is why that's your answer for this question. A primigravida with severe abdominal pain, vaginal bleeding, that is APH, seen at 32 weeks. Uterus is tender. Symphysiofundal height is more than the period of gestation. Fetal heart rate is not heard. Most probable diagnosis, yes. The most probable diagnosis is abruptio placenta. What is going in favor of the diagnosis? Tense and tender uterus, fundal height more than the period of gestation, and the fact that there is abdominal pain. Placenta previa has painless, causeless bleeding. right? And the fundal height would be equal to the period of gestation, and the fetal heart rate is usually going to be normal, and the uterus is usually going to be relaxed with placenta previa. With rupture uterus, the clinical profile would be slightly different. Maybe they will give you a history of previous cesarean section would be there. Maybe she's a grand multipara, right? And again, yes, bleeding can be there. Tender uterus can be there with rupture uterus, right? But why would the fundal height be more than the POG? Right? And fetal heart rate, fetal distress may be there with uterus rupture. Fetus may be dead because of uterus rupture. But mainly, if they are asking you rupture uterus, they would mention superficially palpable fetal parts, superficially palpable fetal parts, or that the uterine contour is lost, or there will say loss of station on pervaginal examination. So these would be your clues. With polyhydramnios also, the fundal height will be more than the period of gestation. But why would there be vaginal bleeding in tender uterus? And fetal heart rate can be difficult to localize if there is a lot of amniotic fluid and polyhydramnios. So fetal parts and fetal heart rate can be difficult to localize. But tender uterus, bleeding, pain like this, it is not going in favor of polyhydramnios also. So these are not your diagnosis. Answer is placental abruption. Now, which among the following is an outlet forceps? Okay, so the kind of forceps that are specially designed for outlet forceps application is Wrigley's forceps. Okay, Piper's forceps are for after coming head of breech. Okay, Keeland forceps are rotational forceps, forceps that are applied for rotation of the head, right? And generally, we are not using rotational forceps anymore in our clinical practice. And thus forceps, there are other forceps also like Simpson's forceps, right? Those are the low forceps. They are the low forceps types. A 26-year-old nulli gravida. Okay, so she has never ever gotten pregnant. Okay, no, with no cystocele, no rectocele, only issue is third degree uterine prolapse. What is the most appropriate management for her condition? So obviously we can't close off her vagina. Leaford colpoclysis, where the vagina is closed, anterior posterior vaginal walls are closed. This is not going to be okay for this age group and this nulli gravida or nulliparous woman. Fothergill's or Manchester operation, in which we amputate the cervix. This is fine for those women who want to retain their menstrual function, but want to avoid a hysterectomy, but their family is complete. They don't want to have children in the future. Then we can think of amputating the cervix. Shirodkar vaginal approach. In Shirodkar vaginal approach, it is similar to Manchester, but the only thing is that cervix is not amputated. So cervix is not amputated, and Shirodkar's modification of Manchester was that only cervix was not amputated. Rest of the steps were similar to the Manchester procedure. So if you quickly recall what happened in the Manchester procedure, cervix was amputated and the cardinal ligaments are plicated in front of the cervix, in front of the cervical stump that is left after amputation of the cervix, to give some support to the cervix, right? Now, please remember that for nulliparous women, for nulliparous prolapse, I have always told you, for nulliparous prolapse, what type of surgeries are best suited? The sling surgeries, the abdominal sling surgeries. Okay, so that is your answer. A woman presents with continuous dribbling of urine 10 days after hysterectomy, which was done for fibroid uterus. Continuous dribbling. All the time she is dribbling of urine. This is not stress urinary incontinence. Stress incontinence meaning that she is otherwise able to hold urine, otherwise able to go to the washroom also, but when she is coughing, laughing, sneezing, or doing any of this work where intra-abdominal pressure is raised, drops of urine pass out. So that is stress urinary incontinence. Leakage of urine happens when the intra-abdominal pressure rises. So this is not stress in urinary incontinence. She is not able to hold urine normally. Right, so whatever enters in, so this is a vagina, okay, and this is the bladder, all right. So what has happened here? Maybe there's a fistula here. So whatever urine is filling into the bladder, it is always dribbling from the vagina. Okay, so she's not able to hold urine in her bladder at all because whatever is filling up here is dribbling continuously from the vagina. So the answer is vesico-vaginal fistula. Okay, now why is it not ureterovaginal fistula? Let's just have a look. See, if this was a ureterovaginal fistula, you would say that, madam, then also it will dribble. If there was a ureterovaginal fistula, then also the urine will dribble. But I will say with a ureterovaginal fistula, there's other side ureter also, no? So bladder can be, this is the bladder, let's say. Okay, so bladder will get filled from both side ureters. Okay, so there is dribbling from the vagina because of a ureterovaginal fistula, but the bladder will still fill up with urine, na? Bladder may still fill up with urine. So she will be able to hold urine normally also with the ureterovaginal fistula. If there is a urethrovaginal fistula, then normally this anterior and posterior walls of urethra are closed off. That is the continent mechanism. Okay, bladder is fine, then the patient will be able to hold urine. So if there is a urethrovaginal fistula, she will be able to hold urine normally. But when she micturates, when she urinates, then urine will come out from both urethra and vagina. Then urine will come out from both urethra and vagina, right? So answer here is VVF, vesico-vaginal fistula. Which of the following hormones are secreted by Sertoli cells and Leydig cells respectively? We know Leydig cells secrete testosterone, we know that, right? So it is not this, not this. Respectively, they are asking now. So it is testosterone, and Sertoli cells are counterpart of the, see, Leydig cells are counterpart of theca cells and Sertoli cells are counterpart of, yes, granulosa cells, right? So Sertoli cells also in the male secrete inhibin. So answer is option number D. Suction and evacuation for MTP is best done till what time? So please remember that suction and evacuation as a procedure can be done up till 15 weeks. That's correct. But please remember, best done till they are asking you. And also remember, even if they had not mentioned best done till, even if best was not mentioned, please remember, for us, Government of India allows suction and evacuation or any surgical method of MTP, surgical MTP, only till 12 weeks. So that should be your answer. So that should be your answer.